Доброе утро, уважаемые гости, уважаемые коллеги. Позвольте извиниться, что мы чуть-чуть с небольшим лагом временным начинаем.
First of all, I would like to give the floor to our Vice Minister, Mr. Iran Shakirevich. Vice Minister presents Ministry of Health and supports endoscopy and oncology. Iran Shakirevich, the floor is yours. Hello, dear colleagues, dear friends, dear guests, participants to the meeting. In the past years, endoscopy has made strides and made this breakthrough. When I was head of the Karaganda Health Department, we were perhaps the first to organize specialized high technology endoscopic center and host a high precision technology. And this was a good message to developing this field in one of the regions. And we didn't have to wait too long while other similar centers started to develop, and now endoscopy has become one of the routine and full-fledged entire field of diagnosis and treatment. As I said, allow me to express my gratitude
and the Kazakhstan Endoscopic Society for the initiative and organization of this important event at which we are present. Now I noticed that this event is also supplied with exhibition of the equipment. Endoscopy is dynamically development, and it plays the key role in early diagnostics of low invasive interventions. If we spoke of transvaginal intervention, the invasive methods were limited only to ADP and etc. But today, the role of non-invasive interventions is so long that I'd like to say this is a separate trend in medicine. And I am sincerely happy to welcome you today, you, the chief endoscopists of the Republic of Kazakhstan. This service is very close to me. A special significance is translation operation, discussion of clinical cases, and this interaction is of great importance because endoscopy goes beyond the routine studies, transvaginal studies, intracerebral studies. What we earlier only heard of now is becoming a frequent practice, the method of study here in Kazakhstan. This is not an exception, but it's also widely used. And each of you accumulates your own experience, and this gives a chance to exchange experience. I'd like to thank again representatives of different companies. And today, the range of different options of medical equipment is so wide that this kind of forum allows expanding the opportunities, and low invasive methods are targeted at improving health of our citizens, of our patients, and therefore the validity of such fora is very significant. And this is not only the platform for exchange of experience, but also exchange of new ideas, promoting the future of the endoscopy. And last year at the Ministry of Healthcare, when we had the Coordination Council, the decision was made to organize specialized endoscopic centers on the basis of regional oncological dispensers. And the goal is to allow state-of-the-art centers of modern endoscopy with state-of-the-art equipment where we could concentrate the best specialists so that these oncological centers with endoscopic trend could accumulate the experience, the methods of diagnostics, treatment, and today in all regional centers have been open not only on the basis of oncological centers but also at hospitals, and I think that today we would hear about them. Therefore, I'd like to wish you a very fruitful discussion, interaction, exchange of experience, and I think that the majority of specialists are present here, and this exchange and sharing of experience would be of great value for each of us. The main thing is communication and interaction, exchange of opinions, and later on the chance to contact. And this is very precious. And this forum provides you this rare chance. Thank you. Thank you very much for the warm greetings, great support from your side. And the next welcoming speech, our Deputy Chairman of the National Research Oncological Center, Mukajanov. Good morning, dear colleagues, dear guests. I am working at the National Oncological Center, and thank you for coming to this second endoscopic forum of Central Asia. You know, this forum for endoscopic development gathers the greatest endoscopists, the best doctors and scientists, and the whole society and broad society abroad also are paying attention to this event because it's of great importance for the development of medicine. It's not only diagnostics, it's surgery, and I think this forum would be of great practical and theoretical validity. It will pass for 2 days. The first day will be dwelling on theoretical approaches, on different workout of methods, and the second day would be devoted to our master classes. You know, our division of endoscopy is conducting many operations, and we will allow you to see quite a number of operational episodes, and this kind of participation and sharing will be of great validity. Therefore, on behalf of our endoscopic center, we are very appreciative for your coming here, for sharing with us your knowledge, your developments, your achievements. We would like to wish you good health, great achievements, accomplishments from sincere heart. Thank you. Dear colleagues, once again, good morning. I'm very happy that you all managed to arrive here for participation in this forum. This is the second forum in 2023. There was the first one. We had 9 countries, some of them online. Today also in the same format. Today will be the theoretical aspect, and we would try to dwell not only on the big endoscopy, but also on children endoscopy and specific aspects of endoscopic. The second day will be devoted to translation of operations of our national oncological centers, maybe 9 operations provided by with participation of our experts. In the small hall, there would be a separate section on child endoscopy, on morphology, and later on some stations, and registration would be done provisionally, and the number of participants is limited. Therefore, try to take this chance. Material will be translated on our site and on YouTube. You're welcome. And I think we would get very fruitful experience. Thank you. Let's start.
И у нас первую сессию, так,
The first session will be started with Mr. Lyubimoslavovich. He will be talking about endoscopic treatment of Zenker's diverticulum, Moscow Clinical Center, Scientific Center. Please, the floor is yours. Distinguished Chairman, Chairperson, dear friends, dear guests, I'm very happy to open this forum. I'm very hopeful that not only the localization of this disease that we start is there a way to navigate the presentation? May I see my presentation, please? So here we talked a lot about endoscopic treatment of the Zenker's diverticulum. And now we'll talk about the treatment of the Zenker's diverticulum. So the method itself that was developed a few years ago means one stage myotomy of the septum of the diverticulum between the esophagus and creating an opening, higher esophageal myotomy, and this will allow the passage of food, and it is considered as a good treatment. Here you can see control endoscopy after 3-4 years. This patient was so the patient had hernia, but later he did not have any problem with this disease since this is a complex Zenker's diverticulum, and it develops, progresses over time. All the central localizations require surgical treatment. All other diverticula, small, large diverticula, so may lead to cricopharyngeal dysfunction. There can be lateral localization, there can be diverticulitis, and there could be recurrent diverticulum. So if you look at our experience since 2014, we had 446 patients. 42% of the patients had a non-standard, had a standard diverticula, and they are considered Zenker's diverticula. One of the common conditions of the diverticulum, one of the clinical demonstrations, the verticulum is 9 centimeters in size. It shows clear bronchial tree. Large diverticulum is the most simple one of all diverticula. Is one that is simple to handle. I mean, so because you have a wide access to the cavity, to the opening of the diverticulum. So your point is that you have to dissect the muscular structures in the septum. You do upper esophageal myotomy, and then you have to remove, get rid of the conditions that contribute to the recurrence of the disease. This is the view of the diverticulum after 3 months. The patient did not have any clinical manifestations, and this patient was an athlete that does bicycles. On X-ray, we can see absence of any complications, any trouble swallowing. There can be diverticula of irregular shape with complex structure. So here you might have to modify your dissection, your myotomy, and there might be some sockets, some pockets that you will have to dissect and bring them together, bring the cavity together. A small diverticulum also presents with symptoms. The diverticulum did not have enough time to fully form. The septum itself is not deep, it is not marked, and there could be certain technical difficulties such as positioning the equipment and limited access to the cavity. There is standard technologies that you can use. Certain techniques that you use in large diverticula are not applicable in small diverticula. The upper esophageal, we can So here we show where the problem is. When you apply clips on the upper right side, there can be a pocket. The mucous membrane drifts to the cavity of the esophagus because of the inversion. Sometimes this so we do it longitudinally. Cricopharyngeal dysfunction. The clinical signs of dysphagia. The diagnosis is made using manometry. When you don't see relaxation of the upper esophageal sphincter and all the problems due to that. So here you provide access to all the muscular structures. Using this technology, you'll create access to the needed space. We don't see any diverticulum here, but the volume of dissection is the same. Upper esophageal myotomy for 4 or 5 centimeters. Another pretty complex situation, lateral diverticulum. Unfortunately, we cannot say whether this is a James diverticulum or just a dislocation. So here you can see diverticulum is located on the left side, and we can see the cavity is large, and there's a problem in the lumen of the esophagus. The neuromuscular component is one of the important factors in the genesis of this diverticulum. We operated this diverticulum, and the septotomy was not long here, did not take long. So this muscular disturbance is required to provide long myometry for 10 myotomy for 10 centimeters, and the deformation of esophagus was removed. We were able to get rid of the problem. When the patient revisited us, there were certain residual clinical signs that after changing the diet were eliminated fully. So here in the esophagus, there is no deformation during the myotomy, all along the myotomy that we provided previously. There was a symptom, but it clinically did not have any significance. So the difficulties of a lateral myotomy, diverticula, is that technically it is very hard to close it and to put clips on the sides. And there is always a pocket left that we cannot dissect, that we cannot get rid of fully. And in X-rays, you will always see this pocket, and you will see this connection. There is a cavity, there is a lumen where you can see that some food will accumulate or might accumulate, and but most of the time they don't cause any problems. The volume does not change. There's the same volume of myotomy, but the conditions are not very good, are not convenient because the tissue is inflamed, and you'll have to provide two-stage hemostasis, and it is very hard to navigate through this structure, and the treatment modalities are widening. So we are able to handle such situations as well. So this control, the follow-up X-ray provides you with opportunity to make sure that there are no complications. So these are there might be such diverticula. You can see residual fluid, or sometimes even bones, or some pills, and so on. One of the extreme manifestations in one of our patients, senile patients, there was a cicatrical stricture in the esophagus, and the operation volume is absolutely the same. So we provided this operation, and on the right, we can see the result after 1 year. Recurrent diverticular form due to the fact that you provide the surgery, not don't provide full surgery. You do diverticulotomy without myotomy, and you can see it's this spastic hypopharyngeal muscle. And after that, we provide the same volume of surgical treatment. On X-ray, you can see there is no sac, there is no residual sac, and the lumen is good. So there were some recurrent cases. We operated these patients for the second time. We provided upper esophageal myotomy, and such part of the operations were broadcasted because they were interesting cases. This this patient who had a fourth intervention, and just a septotomy did not help. Of course, there have to be certain equipment pieces. It might seem technically very simple, but it is a complex procedure. You'll have to have these pumps, caps, distal caps, clips, and this special forceps. So, in conclusion, I would like to say that the Zenker's diverticulum is a umbrella term. The situations are seen in 43% of cases. Endoscopic treatment are effective and may be considered priority treatment methods. Thank you very much for your attention. As always, you provided an amazing presentation. Dear colleagues, do you have any questions? Probably they didn't all wake up. Thank you very much. Next one is submucous endoscopic resection. Mr. Yosef Alexander Mikhailovich, head of the endoscopic center of the University Clinic in Zaporozhye, Ukraine. He will be presenting online. Do we have a presentation? Hello, dear colleagues. My name is Alexander Kilosov. I am head. My name is Alexander Kilosov. I'm head the department in University Clinic of Zaporozhye. I am very happy once again to be one of the speakers. Thank you very much for the organizers, to Mr. Kanat Batarbekov. I'm very happy to present to you. The topic of my today's presentation is endoscopic removal of large submucosal masses of esophagus. This is very interesting topic. Endoscopy, I will show it can be used as minimally invasive procedure in large formations, in large masses of esophagus. Submucosal masses, neoplasms of the gastrointestinal tract, is a collective term that includes changes, the common feature of which is the localization of pathological focus in the submucosal layer of a hollow organ. So the structure, leiomyoma is 75%, GIST 5%, leiomyosarcoma is 5%. Leiomyosarcoma 5%, granular cell tumor 5%, inflammatory fibers polyps 5%, fibromangioma lipoma 5%. 60% are in the gastric region. Ectopic. So in the gastric region, just 60%, leiomyoma, leiomyosarcoma 14%, pancreatic rest 10%, schwannoma 5%, lipoma 5%, NETs 4, glomus tumor 1%, neurofibroma, inflammatory fibroid polyp 1%. Diagnosis. All these masses are found randomly. When you find such formations up to 2 centimeters, the patients can be provided endoscopic removal. When the size is over 2 centimeters, you provide FNA, FNB, and then an endoscopy, and also provide CT. On CT, we can see CT will help us to manage the patient in the follow-up period. So it all depends on the final goal, and it depends on the equipment that you have available. Classification of esophageal leiomyomas. So here you can see different types depending on the location. So endoscopic, they can be intramural, extraesophageal, intramural. They can be so the localization will determine the management and the management of the patient and the selection of the method of the treatment. I came across a very recent presentation publication where it shows the classification of the esophageal masses, submucosal masses in the esophagus. Leiomyoma is benign most of the time. SRG recommends leiomyomas are localized in the middle part of the esophagus. They can be different size and different shape. Clinical signs include common symptoms, general symptoms such as dysphagia, substernal pain, cough, dyspnea. As a rule, the majority of the myomas are asymptomatic. Symptomatically, myomas are when the size is over 2 centimeters, and there will be indications for further tactics, for further examination and further possible removal of the masses. Endoscopic treatment for small or submucosal masses can be removed by resection, AMR, by dissection, if that is just a submucosal uh, this submucosal resection, the stern operation, FTDR. So here it can be debatable. To remove such masses, we use this intellectual energy. This you work intellectually by trying to not damage the surrounding tissue and the surrounding vessels. Endoscopic um, ESD, STR, STR, EFTR is very safe methods. We remove a tumor, we remove a mass uh, inside the tunnel when we are not afraid of complications such as carboxyperitoneum, carboxymediastinum. The tunnel when we close the we we help the patient on the second day to be to not be afraid of some complications. So this helps our patients uh, to recover fast. Such operations might present with complications, insufficiency of the suture, problems with the tunnel, bleeding, perforations, intense carboxymediastinum. This can be seen when you provide this procedure stern surgical treatment of a leiomyoma. As a rule, it was shown in works that tumors are removed, and the selection of the methods is stern. Oh, sorry, STER. So I will be talking to you uh, about three major uh, formations in the esophagus, such as fragmentation. When I came across this publication, it was in April. I, I call this fragmentation of the tunnel that can be seen after dissection. So I like the name surgical management and treatment outcomes in esophageal Leiomyoma. This is this is what this is the formation that was removed endoscopically. Such tumors, they are also fragmented and they are removed from the esophagus. Our clinical example, the patient, you can see this staple-like removal of the endoscopic submucosal resection. The patient has a tumor, and the patient, and here we can see the arc of the aorta that is adjacent to this formation. We decided to risk and remove it endoscopically. The tumor was divided into two because each part is in the tunnel. And on this video, you can see the division of the tumor into two parts. As you can see, the picture is pretty. The goal was to divide this tumor into two, dissect it from all the edges. We cannot remove it, of course, because it affects the submucosal, the mucous membrane. There are many options that you have to use in order to make sure that the patient recovers from the disease. Next one is giant esophageal leiomyoma. We made a dissection in the center with further fragmentation. We've fragmented partly, part by part, and this is very important. The patient was examined previously, CT, ultrasound, biopsy was provided. It was proved that it was leiomyoma. This is the tunnel, and we remove this reject this formation from the tunnel after fragmenting it. This is very important not to damage the mucus because you otherwise you'll have to use other methods in order to recover the patient. On the video, you can see further fragmentation of the formation. And on the next video, you can see the closure into the tunnel opening. We close the opening of the tunnel. The formation is pretty large, but it was localized in the middle part of the esophagus. The patient was intubated, uh, and we manipulated on the posterior wall. It was technically a complex operation, took some time, but the patient was discharged on the 10th day with a positive effect after the treatment. This is 4 centimeter formation. As you can see, this is the lumen of the esophagus on the 6 months after the operation. We can see that the lumen of the esophagus is normal, no dysphagia. The patient recovered very well, very fast, very active young man, and now he feels healthy. But you saw what the size of the formation was. So, in conclusion, selection of the taxes of endoscopic treatment depends on the size of the formation, localization, uh, growth, invasive or non-invasive growth of the tumor, and ASMR and stir is the optimal method of endoscopic treatment of large SMT esophagus. Stir is possible to use to avoid complications and remove neoplasms without damaging the mucous membrane of the esophagus. Endoscopic treatment is technically feasible procedure for the treatment of patients with gastrointestinal submucosal neoplasms, but technically it has to be performed well. Thank you very much for your attention. I wish you all productive day. I would like to congratulate the Kazakh Endoscopy Society with this forum. Thank you very much. Very happy to be with you and uh, and to present to you this report. Thank you very much.
Thank you very much, Alexander Mikhailovich. So you can hear me. Thank you so much. So we're a little bit behind the time now. Let's pass over to the next speaker, endoscopic resection, Malkov Vladimir Alexandrovich, the head of endoscopic department of Clinic after Pirogov, St. Petersburg. You're welcome. Good morning, dear colleagues. Thank you very much for invitation. I am for the second time in Kazakhstan, the first time in the city of Astana. I'm very impressed with everything. Thank you very much for your presence here. And I have only 15 minutes to tell you of the topic that Alexander Mikhailovich touched upon. We did not agree about it, but nevertheless, I would try to show another aspect of the same topic. I would like to start with the following. I know that at this floor there would be Hilafir, Professor Kajiba, and my endoscopic way started in 2005, 2006, and I was inspired by Kashida-san, Ue-san, and I tried to follow their activities, and now I already managed to accumulate some experience to share with you today. This is our clinic. Actually, it is an average size in St. Petersburg. It was founded in 1860. At that time, it was advanced, and today it is an assembly of buildings. And we are dealing with treatment of patients. And I'd like to start with the historical look. In order to go forward, we should know what has been done. Without it, no progress is possible. Therefore, I would start with the historical survey of what has been done for us to allow to employ endoscopic approach. And so what do we know? In 1871, for the first time, operation was done on resection of the food pipe because of cancer, but the patient did not survive. In 1913, Franz Torek, for the first time, performed resection, and the patient survived. That was a small surgery of the food pipe, but it was very significant for as a fagal object. in 1950s, Boris Petrovsky developed method of the very soft enucleation without resection, and in 1960, the first publication of a number of operations on resection of the esophagus. And later on, in 1992, there were different endoscopic methods. At the beginning of 1984, the first attempts of endoscopic resection, and in 2003, endoscopic resection, gastrointestinal endoscopic. And today it is the endoscopic submucosal surgery, less and less hybrid technologies are being introduced. Myoma, gastrointestinal cysts, and as you see on this table, the percentage of these things in the majority of cases are benign, such as gastrointestinomas. As to localization, the upper third, only 10% of tumors, they can be encountered rarely, and including glucogenic cyst. The medium part myomas frequently are encountered, and the lower part intestinal and lipomas. The classical picture, non-symptomical picture, very rarely dysphagia. And let's look at gystological practices. The question is the need of their resection, because this zone is very sensitive and the size of the tumor is important. And we know that the desirable size is up to 2 centimeters. Diagnostics. Well, I would like to add that X-ray of the esophagus and the level of dysphagia and the resection of such tumors when the patient suffers from cancerophobia, when a person is panically afraid of tumors, and even psychiatrists say that only after such status they agree to surgery. And accordingly, there is another side of the problem. So there is one small problem because we are going to more acute technology of computer tomography and magnetic tomography for complex cases. Methods of resection. These are small indications, less than 3 centimeters. Big ones, if we look at the number of works, technologies, word system, uh, but nevertheless, sometimes patients are afraid to run the risk of such open surgeries, such as Watt's technology, and they prefer endoscopic treatment. Preconditions, again, historical development. For the first time, the section was forwarded by Inouye-san, and in 2012, Professor Zhu for the tumors of esophagus. And I'd like to share with you with some small video. I would like to switch on the sound. I will be commenting to show what other calculus can be encountered. This is one of the diagnostic studies. There is a tumor. It was located accidentally during computer tomography. The patient did not want to be observed. It is smaller than 2 centimeters because we knew that usually it did not provide resolutionary picture, and endoscopic stenography, we noted the wall, noted the distance, then made marking to employ soft mode with instruments of Russian production. In this case, we ended by going to 5 centimeters from the tumor and getting away at this distance of 5 centimeters, we introduced solution which helped to uprise it. And the next moment is intrusion into the tunnel of endoscopic tool, and thereby we take submucosal substances, and this operation is accompanied by not great number of vessels, and this makes it easier to get easier to the tunnel. And that tumor which was resected, we do not see it, and accordingly there is a great problem of detecting it, but there is only one way. As you see, there is a tumor. We do not see it. It's very difficult to differentiate it, but here it is. The same fragment can be shown, uh, and access to such tumors can be done differently. Sometimes you have to go through mediastinum, and because these tumors like lipoma, so they differ in coloring, but for resection we need to know how to move towards them, but it differs from muscle. It has more yellowish uh, layers. It's the fourth layer of the muscle, and the first task at resection is to just take it away from the mucosal cover, and further on to do the myotomy of this tumor. The whole operation takes 25 minutes. So I tried to show the main moments. Well, I love the picture. You see, we entered the muscle, and the last part is when we resect this tumor. As recurrence in these cases, non-recurrence took place as of today, but recurrences can take place, I know from other people's experience. Recently, we offered such a program of communication with morphologists, and options of response to resection. Morphologists think that tissues should be preserved around the capsula. Endoscopists say R1. They see the capsule but do not see the surrounding tissues. But endoscopic method shows, Alexander Mikhailovich, in our case, we see the capsula. If the capsula is not offended, this is a relatively radical resection. But if we look to the sources of literature after such resection, the frequency of recurrences is extremely low. And this contradiction with morphologists actually can be explained by their inopportunity to see the tissues. The submucosal tumors require individual approach. Endoscopy is the golden standard of diagnostics. If there are complications, they can be very serious, but if the approach is selected correctly, then it it is considerably safe with positive outcome and with good rehabilitation and good life of the patient. Thank you very much. With modern technologies, company Erba with the good knife, which allowed us to perform this operation. Thank you very much. Thank you, Vladimir Alexandrovich, for this exciting presentation. If possible, we're a little bit behind. There is no place for discussion now. The next endoscopic treatment of scar stenosis, Batarbekov, of intervention radiology. Hey. Good morning, everybody. On story narrowing, we have sufficient materials in this clinic. For the 4 years we performed to 55 treatment of scar stenosis after post-chemical and on the background of stenosis and stenosis. On clinical recommendations, we have recommendation of American and clinical protocols of Kazakhstan. Unfortunately, they're a little bit outdated. By nature, we study post-inflammation and post-traumatic, and the character, the chemical complete high and the low location and 2 or 3 centimeters. And we had a patient who had 15 centimeters. We did it in conditions of stationary. Later on, we sent him to ambulatory conditions, but now we work on dissection knives. The tactic of treatment is bushing with knives or with and scar stenosis, which you may see this is in the medium part of the esophagus, and at one of the pictures you may see pushing with the cup. That's the ring of Shatsky. That is with the balloon, Nesta balloon, three-stage, 13, 14, 15 centimeters. They're very comfortable. And stenosis of erratic on the background of lengthy scarring process. And here the new cups, which have two sizes under control. There is Buzhinage and Buzhinage of stenosis of the esophagus with the cups. Here the video file. Well, doesn't work out. All right, unfortunately. And here we have the results which we had for the patients. The length was different. Most frequently they were short and subtotal, total. In rare cases, the outcomes were good. Distant in conditions of our stationary. The main causes chemical burnings after the structure of the esophagus. Stenosis was short, 15 centimeters. Subtotal stenosis, 15 centimeters. And the big stenosis up to 17 centimeters. And later on, we do not do Buzhinage. And total and subtotal stenosis from 1 to 3 stenosis and Buzhinage with perforations. This is Buzhinage with cups, the first generation of cups. We had to change 11, then 13, and up to 15. Later on, we obtained cups of the next generation of two sizes, and this is dissection of epistamosis of Medics company. Very comfortable, under control, and good outcomes. We tried to do needling endoscopic anastomosis in the intestine, and here also very prognostic endoscopic recanalization of stenosis and strictures. And the patient came with the stricture of the upper part of the esophagus with unlevel contour, and without suspicion it was forwarded to us for treatment of the stenosis, and we actually found here in the lower third part the cancer of the esophagus, and biopsy confirmed this conclusion. And we found the second reason, appearance of the cancer of the lower third part of the esophagus. Well, you may see that X-ray may not detect such cases sometimes. And stenosis of trachea, we used the dissection knife and employed coagulation with corticosteroids, and then came to the control, and there was no recurrence. And in conclusion, I'd like to say that mandatory Röntgenous X-ray scopic studies with contrasting and patients with lengthy stenosis better should be treated in stationary conditions. After Buzhinage, we need to do resection of single stenosis. Thank you for your attention. Thank you, Mr. Batarbekov. The next speaker, the experience of introduction of poem of National Research Center, Abdekadirov Majid Kolikovich, Master of Medicine of the Center of Tasiskanov.
Please switch on the microphone. Hello, dear colleagues, dear friends. I'm very happy to hear you all, to see you all. Today I would like to talk about my experience of poem in our center. So what is achalasia cardia? We will know. So from 2019, we can see that the incidence is 1 per 100,000 with what are the risks? The risks, the first theory is genetic, the AAA syndrome, all growth syndrome. It could be herpes infection, autoimmune diseases. What are the signs of achalasia? Those are dysphagia, regurgitating food, saliva or fluid, chest pain, coughing at night, and weight loss. Weight loss, pneumonia, and others. Diagnosis: the gold standard is manometry, high-resolution manometry, according to Chicago classification. I know there is no manometry in Kazakhstan for now. For now, we make diagnosis using X-ray and of course using our endoscopy. This is a Chicago classification, 4th edition. There are main types: type 1, type 2, type 3. Achalasia first shows no motility in the esophagus and in the presence of high pressure band. In type 2, there is always non-relaxed sphincter, and the third one is characterized with chest pain, marked pain. Methods of treatment: there are surgical and non-surgical methods. Non-surgical pharmacological therapy for patients that cannot have surgical or endoscopic treatment. Botox, next one, and pneumatic dilatation are non-surgical methods. For surgery, this is Heller's surgery. Or Professor Bracken made a great contribution to the esophageal surgery, and Mr. Academic Aliyev, Baymukhanov, Kazhirov. These are the results of our work since 2016 through 2025. We conducted 55 operations in 55 patients aged 9 to 73. Average age 42 years old. This is a working population, and or gender 51 over versus 49, 51% men, but previously it was women who prevailed. Or duration of the disease ranged from 2.5 months to 16 years. 7 patients had a pneumatic dilatation prior to poem. For Eckert scale, the average is 8.5, 8.4. All of them all cases were completed endoscopically. On the diagram, you can see the number of patients. The blue shows the number of patients. This year, hopefully, we'll see growing the time. The operating time goes down over time, as you can see. This is a video clip. If I may ask you to play it. This a patient from the US came to us in order to have this operation. He saw our publications on Facebook. He called us and found out about our prices and came here to be operated. These are the main stages. This is the incision, so this section or incision. We create a tunnel. We dissect this layer. Myotomy length is 12 centimeters on average. The shortest one was 7 centimeters. The longest one was over 20 centimeters in type 3. In clipping the defect. Next slide, please. As I said, middle myotomy, 3 to 9, shortest one 6, and the longest 25 centimeters. Intraoperative adverse events were seen in 13 patients, carboxyperitoneum in 8 patients. At the very beginning, we made a long incision from the stomach side, and too much carbon monoxide led to carboxyperitoneum. As of today, we limit it in order to get rid of the reflux. Carboxythorax was seen in one patient. In patient we provided below. Then there was massive bleeding during intervention in one patient, and 5 patients got mucosal perforation. In the third and fourth stage of achalasia, there were problems of clipping. A patient in one case had some complication in follow-up. Patients were followed up for 1 to 5 years. 50% were gained weight. It went down to 1.4. Reflux 29 patients. Clinically endoscopically grade A 9 and grade B in 2 patients. These 2 patients, they were non-compliant. They didn't take any inhibitors. This is why. This is the follow-up X-ray. We still provide it. After 1 day, we give contrast agent. But according to guidelines, this is not necessary. This is not required. Patient with long anamnesis, history, achalasia type 3. We dissected about 25 centimeters of the muscular layer in the upper right corner. Endoscopy after 3 months, and after 3 years, we see diverticulum. Signs came back. With last week, we conducted balloon dilatation. We'll have to follow up if the patient, uh, if it recurs, the patient will have to come back. Conclusion poem for achalasia is highly effective and safe intervention that improves the condition of patients. The incidence of intra and postoperative complication does not exceed the data of many other studies. One of the reflux is one of the complications, and it is one of the disadvantages of poem. And hopefully, we will implement this technology further. Thank you very much for your attention. So, on the third year after the poem, there was this symptom. Did you not have that you randomly dissected the longitudinal layer? No, we dissected fully from the abdominal segment. We didn't go down to the stomach because we thought that 25 was a long distance. Was one of the uh, first poems. I had a case. We we had to dissect. So when we dissected, there was this formation of the septum that the patient had after he came back. We didn't have any spasm. We provided dilatation and all the symptoms went away. The patient had a spasm here, so we did that. Thank you very much for your presentation. Rahmetova Medical University Astana. Barrett's esophagus, gastroesophageal reflux disease, diagnosis and treatment. Good morning, dear colleagues. I am very happy to present on this forum. I'm very happy to interact with our endoscopists, our colleagues. I would like to wish Kanato Marzakovich to you and your uh, team, to all the endoscopists, further improvement of your services, of all those new studies, not only in diagnostic but also therapeutic methods. We are all happy to see your successes, and we are very happy with that. Happy for that. Thank you very much for giving me the floor today. I will be talking about gastroesophageal reflux disease and its complication, Barrett esophagus. And allow me to remind you, this is a chronic disease. We don't say that it is a chronic disease. It is based on the pathogenesis. This is the primary disturbance of the motor function. This is the upper part of the GI tract function of the uh, esophageal gastric passage, and pathognomic symptom heartburn. So the makeup can can be not only the gastric content but also the duodenal content. And this all leads to clinical signs and the long course in this. There might be some changes in the mucosal layer of the esophagus, inflammatory, dystrophic erosion, metaplastic changes. One of the significant complications of GERD is the Barrett disease. We know that it can we know that it can cause adenocarcinoma, gastric adenocarcinoma. In 2017, there was a Lion consensus. Patients with if there are no clinical signs, this will not be enough for the diagnosis according to Lyon consensus. But with typical clinical diagnostic criteria, uh, there is a stage 2 disease. Or unfortunately, we have such patients, and some of them do not have clinical signs. They do not have manifestations. And when they have complaints, you have to do after you terminate antisecretory therapy. You have to conduct the differential diagnosis with esophagitis, eosinophilic esophagitis. When in biopsy, you can see more than 15 eosinophils, and this talks about eosinophilic esophagitis. When there are no changes in the mucosal membrane, only grade A, it is recommended to conduct quasimetry. You have to also terminate proton pump inhibitors, and you also have to confirm the diagnosis of GERD. So in September, the Barrett esophagus is a metaplasia when the epithelium changes to the cylindrical cells. This is the only pre-cancer disease that may lead to adenocarcinoma of the esophagus. There are 3 types of the cells: fundal, uh, transient, and specialized. And with cylindrical epithelium, pathologists talked about this at the beginning of 20th century. These places were described as heterotopia. So Norman Barrett is an English surgeon. This nosology was first described by Philip Roland in year 46. And there was connection was determined in 1953 between these 2 conditions. Etiology of Barrett's esophagus is GERD, reflux of the gastric acid. There are many things that are unknown. In many cases, Barrett's esophagus is acquired, and we don't see the that it is congenital. Certain alleles may predispose patients to develop Barrett's esophagus. In the past 50 years, the disease has been growing in number. Male develop it more often. That is, non-Hispanics, white people, patients over 50 years old with central obesity. These are the predisposing factors. Smoking history in the past, family history in first-line relatives, genetics, certain mutations may lead to Barrett's disease. Patients, so these risk factors create a high risk for such patients. Such patients have to be screened. Our patients don't like endoscopy, they have to be persuaded, but this has to be done. So here I would like to show how additional etiologic factors such as gastric acid may lead to the disease. There was a study on mice. An anastomosis between esophagus and duodenum was made after some time. So the acid led to the formation of Barrett's esophagus cells formation. CDX2 marker was found. So goblet-shaped goblet cells were found. Pathophysiology. The pathophysiology is not known. Progress was made in determining molecular changes and the main in the main types of the cells. The results of the studies have shown that the acid affects the cells of the squamous epithelium, and that they secrete inflammatory cytokines, interleukin 8 and interleukin 1b, that so bile acids increase CDX2. This is a factor for intestinal differentiation, and the MUC2 gene that is specific for goblet cells in normal lines of esophageal cancer. Up to 90% of patients have a clonal aberration of the suppressor gene for cancer suppression gene P16, and the mutations of CDX2 and TP53 are the early molecular factors. Here you can see morphologic diagnosis of the Barrett's esophagus. We do not make diagnosis before we confirm it morphologically. So you can see the character of the epitheliocytes, proliferation and dysplasia. For the clinics, these two interconnected diseases, those are GERD, that is heartburn. So you have to ask the patient what heartburn is for them. Acidic regurgitation, dysphagia, pain in the the larynx. When you speak with the patient, you have to ask about this. Also, pain, chest pain, chronic cough. This also we have to work with lung therapists, with lung doctors. Many specialists refer them to us, such patients, and also send to gastroenterologists, melena, or weight loss. But in some patients, signs are not present. So for Kazakh people, symptoms are not seen. Perhaps our pain threshold is high. Oh, so at the early stage, it is not. It is detected not so often. Our patients deal with it for a long time, and according to the Gerson study, 40% of esophageal adenocarcinoma are diagnosed in patients with the Barrett's esophagus with with an absent history of clinical symptoms of reflux. So we have to take this into account. If there is a hernia of the diaphragmal opening, you have to assess history, the course, and you have to find these markers that may lead to Barrett's esophagus. Diagnosis made based on the clinical signs, the length of the cylindrical epithelium has to be at least 1 centimeter in length. And when you determine during endoscopic study, you have to find symptoms of Barrett's esophagus, and they have to be confirmed using endoscopic biopsy, and you have to take biopsy from all visible parts. When you find dysplasia, you have to confirm it in with histologist, and with such histologist that specializes in this field. Of course, the gold standard is esophageal and the transepithelial selection of the samples, and this may increase the effectiveness of standard endoscopy using biopsy forceps. This is not included in the clinical guidelines of the US for now. Using chromoscopy improves sensitivity and specificity. In the United States and in the Netherlands, AI is used in order to develop a system that helps determine a neoplasia and to find damages or lesions. Moreover, there is also non-sedative transnasal endoscopy. You know that non-doctors can perform it, and we can also use special capsular sponges, methylated desoxyribonucleic acid, and other chemicals. So follow-up protocols depends on the dysplasia level. If there is no dysplasia, you have to conduct endoscopy every 5 years. If there is a undetermined dysplasia, you have to repeat after 6 months. After um, 6 months with the inhibitors of proton pump inhibitors twice a day. With if there is a progressive course, you have to follow the protocol for LGD, low-grade dysplasia. If endoscopic eradication therapy (EAT) is not possible or cannot be conducted, endoscopy has to be repeated in 6 months, and then after 6 months, every year, if the dysplasia did not change. High-grade dysplasia, if the mucous membrane is flat there with HGD, EET is conducted in order to remove metaplasia. So you have to conduct screening. The American College for Gastroenterology provides us technologies for screening. They were presented in 2022. Screening, endoscopic eradication therapy, it lowers the incidence of adenocarcinoma. Screening for Barrett's disease has to be conducted in patients with chronic symptoms of GERD, where there are 3 main risk factors. First is male, age over 50, and white men. Also, smoking with obesity and Barrett's disease. History in previously. We know that there is a style, an image, or this lifestyle has to change, and you have to pay more attention to this fact. Increased end of the elevated head end of the bed. Also, we analyzed 50 publications that related to the diet. They showed a positive correlation with the disease course. Also, intake of coffee and tea. Tea does not affect, but the analysis of 60,000 patients, 61,000 patients confirmed that the GERD, that smoking, alcohol, fat food can lead to reflux. And vegetarian food that is not characteristic of our field, it correlates negatively. And the systematic review that was conducted in 2017 demonstrated that GERD symptoms are seen in patients over 50 years old with obesity. And that prospective cohort study that was conducted, patients with obesity that had a structured program for weight loss with physical activity, not only lost weight, but also they demonstrated that the severity of the disease went down. And in 2019, the thing that I talked about, there was the tea for our region. This was critical to lower the consumption of tea. And also, we have to account for the proton pump inhibitors. So the validity was first grade. These are the first line agents in treating these patients, and also with erosive esophagitis. We also have to take into account other diseases. Prescription, the long prescription may lead to other symptoms that are characteristic of patients for senile patients, elderly patients. Proton pump inhibitors provide chemoprophylactic effect. This will lead to the reduction in the neoplastic formations H2 blockers were studied as well. Our gastroenterologists prescribe H2 blockers. Treatment with H2 blockers did not show their significance, and the H2 blockers lead to cellular proliferation. And the patients with Barrett's disease, they should not be used. And proton pump inhibitors their use lead to re-epithelialization of the mucous membrane, and it lowers the risk of developing the disease. I would like to talk about the proton pump inhibitor, rabeprazole. It accumulates in the majority of epithelial cells. It creates, it affects, it helps control the nocturnal heartburn, and this agent inhibits the secretion of the acid, but also it helps produce saliva, and this helps to secrete mucins, and this creates a cytoprotective effect. So it has to be divided into two intakes. This helps re-epithelialize the mucous membrane. Apoptosis index has to always be taken into account. Proliferation index goes down in squamous cell membrane. In conservative treatment with a double dose, it takes about 2 years. It will give a positive dynamic. And those endoscopic methods, those are radio ablation, cryotherapy, hybrid argon plasma coagulation, endoscopic resection of the mucous membrane, that is EMR, and endoscopic submucous dissection, ESD. Prognosis. This is my last slide. It depends on the stage, on the degree of dysplasia. Patients with non-dysplastic Barrett's esophagus have a lower risk for developing neoplasm, cancer, and early follow-up or early observation will give good prognosis. Use of endoscopic methods of eradication will be helpful, and prognosis will be favorable under these conditions. Thank you very much for your attention.
Thank you.
Thank you.
I think Q&A session will come later. Endoscopists, we know diagnostics, we know the treatment, we fully just entrust you. Thank you very much. Some small changes in the program. Speaker from Uzbekistan would not be able to speak, and we will have a reporter, the head of the endoscopic department, Balur, and his report is devoted to submucosal invasion. Good afternoon, everybody. I'm very happy to be present here for the second time. I am happy and grateful to my friend Fanat Batarbekov, and today my topic after resection. We get invasion, and therefore we studied the outcomes of our center. only our center. But historically, we met with Canada in 2018 in South Korea, and then in 2019 we also organized in Mongolia together with Koreans a conference. And then 2 years ago we were here at the first forum. Um, so 7 or 8 years have passed. Mongolia takes the first place in the world on stomach diseases, and the level of mortality is very high. The country is not big, but the population only 3.5 million. This is not small, but unfortunately, we take the first place. This sets the great responsibility on us endoscopists to improve diagnostics and early detection of diseases of uh, this kind. According in Mongolia, there were 2,300 diseases among men. And in 2002, the cancer of stomach happened in 185 cases. And since then, we try to detect at early stages treatment of gastric cancer. There are different uh, just instructions, but the golden standard is European, American, and Japanese. We frequently employ these Japanese treatment guidelines because it is very uh, technically applied and popular in Asia. It has a high degree of aptitude and good outcomes. There is American guideline, but if we look at the general picture for therapy at early stages, well, still remains some limitation at stage K1 and mainly at the mucosal layer. If we compare indications of European and Japanese recommendations, the Japanese criteria is more limited, but I think this can be explained by the conclusions of the pathology anatoms. And there is subtle difference, regardless of non-opportunity to detect the submucosal layer with early cancer, with availability of the manifested invasion at T1B, we should not take the surgical methods of treatment, but we still prefer endoscopic methods. Now we are employing nomogram for predicting metastasis, and the main factor, the size of tumor, histological type, the depth of invasion, and also the border of resection and metastasia in lymphatic nodes, and to take a decision on the need of surgical intervention. We know that the risk of metastatic recurrence depends on the depth of invasion into tumor. The assessment of resection can be done with a different grading approach. Endoscopic treatment is good in terms of results. It's less invasive, economically cost effective, improves quality of life, But early cancer with non-indifferentiated histology traditionally does not suit to endoscopic studies, but mainly our study. As you know, the aim of study is to evaluate the clinical outcomes of endoscopic dissection if the tumor gets deeper than 100 millimeters, um, and if it is more, there is direct indication for surgical interference. In these studies, about 3,000 patients were covered for 15 years. Among them, there are patients who, after surgical period, had inflammatory invasion. Of them, 47 patients are being observed and 63 had surgical interventions. And only one patient had metastatic complications. Only 5 patients also had metastatic complications later on. And treatment with dissection is expanded now. And here you may see that out of 1,055 patients, 55% had invasion with depth 1.7 to 2, and metastasia was located only in 5 patients. That is 20%. Let's come to our study. This study is based on data in our clinic. For 3 years, we had 248 mucosal cancer. Histology proved progression of the disease. From the total number of operations, 36% had more than 3 centimeters of size and 2% lowly located tumors. But once again, it's only in our hospital. 33 tumors with invasion in the submucosal layer, and we had the external observation. Only 4 cases we detected the metastatic cases, and then operations were undertaken. All 4 cases of a metastatic complication had outperforms, and as a result, the 5-year period has not been yet analyzed. The study actually has not defined 5-year survivability, but it requires further observation of long-term outcomes. As to observations after dissection, the average follow-up duration 5.5 months, and frequency of recurrence was 3%, and recurrent 8 times, and repeat biopsy 1 time, that is 3%. The total endoscopic findings among patients, dissection of scars, 95% stenosis, only one case, no new malignant tumors were detected. We think that there should be taken more detailed approach to metastatic and recurrence cases. And can ESD be used to superficial submucosal uh, of stomach cancer? We think yes, it can be done. But the selection of percent for minimum risks of metastatic and reflux complications and careful patient selection to ensure low risk of LN metastasis. My conclusions: most submucosal invading EGC were undifferentiated and larger than 2 centimeters. Despite being outside traditional ESD indication, complete resection was achieved in all cases. Submucosal depth and undifferentiated histology were significantly correlated. One local recurrence occurred during short-term follow-up. ESD may be an acceptable option for carefully selected patients, especially those who are unfit for surgery. And close post-ESD monitoring remains essential, and ESD should be cautiously considered in select SM invading EGD cases. Careful follow-up is essential, especially in undifferentiated cases of cancer. More data are needed for long-term outcomes and lymph nodes. Thank you very much for attention, and we would like to wish and I would like to invite you to our conference, which will take place in October in Mongolia. I officially invite Kanat Viktorbekovich, my friend, to come with his team and give presentations at our conference. Thank you, Balur Bayur Bala. Thank you. Thank you very much. Balur, thank you very much. One of very active operating endoscopist in Mongolia, vice president of endoscopist in Mongolia. You have about 100 endoscopists, already 200 endoscopists. And also, like in our case, they have active operating endoscopists, about 20 of them. Thank you, Balor, very much. You always attend our events, never refuse. Thank you very much for that.
Фурил Шахай, Амбала.
Kirill Shtakhai, also from Mongolia. Treatment approaches to refractory treatment of GERD. They have very good results. They deal with anti-reflux therapy. Uh,
To be here is my first time in Kazakhstan. Today we are talking about new treatment way of refractory GERD in Mongolia. GERD is very frequent worldwide with a prevalence ranging from 7.4 in Southern Asia and to 19.6 in Central America and affect both sex and same adult. Last 30 years have been almost 80% increase in prevalence, mainly attributed to population aging and change of the lifestyle and dietary habit linked to the obesity epidemic. GERD is a common condition in which the reflux of gastric content into the esophagus can cause an uncomfortable symptoms or complications. Also, GERD is the main risk for bad esophagus can significantly affect patient quality of the life and can lead to esophageal cancer. GERD is a threat to the quality of life and poses an increasing public health burden worldwide. One of the there's major mechanisms involved in a GERD. Pathophysiology also include mechanical incompetence of lower esophageal function due to short rate of the low resting pressure, impaired esophageal clearance, impaired mucosal barrier, and delayed gastric emptying. Adjunctive risk factors are the presence in the head hernia, increased intra-abdominal pressure, seeing obesity, bile acid reflux, excessive alcohol or caffeine consumption, smoking habits, and use of certain medications such as nitrates, calcium channel blockers. One of the biggest reason of the GERD is height hernia. The height hernia is the main cause of the structural abnormalities of the EG junction, which is increased intra-abdominal pressure caused various reasons of the common causes. There is a type of height hernia, grade 1, 2, 4. About the diagnosis and management, diagnosis the chest X-ray, barium swallow, endoscopic, and esophageal manometer, CT scan, and others. About the management, asymptomatic height sliding hernia requires no treatment, medical management with H2 blocker agents and PPI in a patients, and reflux procedures and height hernia are prepared. About the treatment, several esophagus, and we will recommend it if there is no PPI treatment results. The recommendation is anti-reflux surgery. Also, the hiatus hernia, there is a laparoscopic and anti-reflux surgery recommended. There is a multiple way of the endoscopic therapies, and the first one is a transoral incisional pontification. The aim of the TIF is perform endoscopic pontification by reestablishing the flap wall mechanism with 3 centimeters. Second one is medigas ultrasonic surgical endostapler. Also use combined microvisual ultrasonic and surgical stapling capabilities into the one device. Next one is non-ablative radiofrequency treatment. It's endoscopic guided method involves the application of the radiofrequency to the muscle fibers of the lower esophageal junction and gastric cardia. About the endoscopic application devices, that one hydrogelic elements for control requires a slim gastroscope that work as a light source. Is the advanced single-use product of the company that has acquired the applicator technology after trouble of the applicator devices. The next one is anti-reflux mucosectomy and anti-reflux mucous ablation. Compared to about comparison of current endoscopic therapies is the arms and armor is showing great result. comparison with other techniques. In other world guidelines, ESG guideline advises that TIF is possible role at the most mild patient who are unwilling to the PPI or undergo surgery. About the arms is low quality, strong consequences. Compared to the other technical clinical excellence, safety of endoscopic therapy is anterior-surface mucosectomy clinical success range between 58.2 100%. It's we're showing great results. Arms endoscopic procedure to rebuild the mucosal plaque wall grade submucosal fibrosis after the mucosectomy at the esophageal junction. The procedure standard technique is based on the endoscopic EST, at least 3 centimeter late, 1 centimeter is the esophageal side, and 2 centimeter is the stomach side, which late of mucosal dissection at the cardia measured in retroflexion from the gastric side. If we see the history of arms, 2002, Professor Harvey and it is reported that first cases of arms, first case suggests that arms may be the effective anti-reflex endoscopic operation. And the 2014 first arms pilot study revealed it. And next one is 2018 arms going to the next new way of the ARMA, and which is anti-reflex mucosal ablation used by and 2021 the ARMS and ARMA systemic review and analysis is reviewed. How can we evaluate the efficacy of ARMS? That one is very simple and very useful, very easy. The evaluation of the clinical symptoms related that GERD, health-related quality of the life, and GERD questionnaire about the 24-hour esophageal pH monitoring, plaque grade score involved the high health grade classification, the use of the acid inhibitors. Next one is about adverse event of the arms. There is two kinds of complication we are happening. It's immediate complication or delayed complication. Immediate complication is bleeding. The percent is 5.4, and next one is delayed complication is esophageal stricture. Of the patient of the 11.4 patients feeling some of the dysphagia. Arms in Mongolia. There's no clinical or nationwide estimated data in Mongolia, but 2017, there are some of our researchers are in stochastic and etc. revealed that the range of the Mongolian GERD prevalence is 28.9, and northern side of the Mongolia is more have GERD symptoms. In our center, anti-reflex mucosectomy, we have some research. In this study, we included 27 patients with treatment refractory GERD, all received arms, all cases arms of restored EST, and the objective was evaluate clinical and quality life of arms outcome patient who underwent arms. The evolution of symptom improvement measured using GERD questionnaire and plaque grade was tested using the Hill grade classification. We are showing that some patient, there's a 27 years old male patient, GERD symptoms start from 5 years ago, and PPI usages of 4 milligram, POU in last 2 years. The picture is shown our forearms. There is a GERD grade C2D, Hill grade is 4K. The post arms 6 months later, GERD symptom revealed decreased, and some of the grade, GERD grade A, Hill grade down to 1 with this current change. The total patient, our study, there is a total patient, the 27 patient, procedure rate is 100% EST, mean age was 59. Total questionnaire dropped from 11.29 to 6.23. There is estimating results are showing. Also, Hill grade for the arms, there is a mean range is 3 after the Hill grade is 0.27. About adverse event, there is a 4 patient related adverse event. There is a dysphagia, 3 patient feeling dysphagia, and post-operation bleeding is only 1. But stenosis next. About the stenosis, the patient has done balloon dilation to time, and after the balloon dilation, some of the symptoms have disappeared. Conclusion. In Mongolia, ARMS is a new treatment of the refractory GERD patient. Our clinical series of ARMS for GERD symptom improvement of symptom, height integrate showed excellent short and midterm result. And ARMS is a safe and effective procedure. What about the key messages? Several minimal invasive endoscopic techniques have been developed in recent years to fill the gap between PPI and the surgery. ARMS is an old endoscopic procedure to rebuild mucosal fluff wall at gastric hernia, and ARMS, and more recently, ARMS is a safe, effective endoscopic intervention for GERD. By utilizing endoscopic techniques and potentially targeting multi-antibiotic mechanism, ARMS have been potentially become gold standard endoscopic intervention for GERD. Select the patient. Thank you so much. Sharing is caring. See you in Mongolia.
Thank you so much. Dear colleagues, we don't have any connected with. Yeah, okay, yeah.
Okay, can I have? Oh,
sorry.
sorry. Can I have one question, see?
Kurilshagay, Dr. Kurilshagay,
Sorry.
we have
I have one
questions.
question. I have no experience on AMA and arms, but I just like to know what kind of procedure you use for EMR. Usually in the cardiac area, sometimes very difficult to go approach to the region, and also I suppose that you use a transparent cap. So I imagine you use an EGM, aspiration mucosectomy or something.
Excuse me, can you repeat that?
What kind of procedure of EMR you use
we are
for AMA? Yes,
I-
arms.
all the cases we are using EST.
Conventional ESD? ESD procedure. Correct. Okay, gotcha. Correct. Thank you.
Okay. Unfortunately, we don't have any connection with Prokhirinoy professor, and instead this, we have a welcoming speech from Russia, from Starkov Юрий Геннадьевич. Please. У нас не получилось связаться с
Parahirinoza, we were not able to connect with him. Doctor of Medical Sciences, head of the endoscopy department, National Medical Center after Vishnevsky. Mr. Sarkofi, please. The floor is yours. Dear colleagues, dear friends, from the bottom of my heart, I would like to welcome all the participants of the second Endoscopic Central Asian Forum. I wish this amazing Congress productive work, successful presentations, and lit presentations from operating rooms. I am hopeful that this will be a successful forum because there is a great number of experts coming together from around the world to Astana, and I'm sure that these two days will be successful and productive for all participants of this amazing forum. I would like to welcome all of you on behalf of the entire Endoscopic Society and the specialized society and the Russian School of Endoscopy and Surgery and the National leading center, National Center for Surgery after Vishnevsky. Once again, I would like to wish you productive work and best of luck in your professional life. 2 amazing May days. Thank you very much. Yuri Gennadievich wanted to come to us, but due to his tight schedule, he is vice endoscopist, chief endoscopist, so he wanted to moderate one of our sessions, but he couldn't make it here. I would like to thank you. We are ending the first session. Next session will be about gastroduodenal field, and now we would like to invite our next moderators, Mr. Mkhabizadamon. Dear colleagues, we have a tea and coffee station. If you'd like, you can come and take a cup of tea or coffee. Next moderators will be Indira Hamitova, Kirill Shishtin, and Chunson U, Professor Chunson U. Please, the floor is yours.
Дорогие друзья, мы продолжаем. У нас
Distinguished friends, we continue gastroduodenal zone endoscopy, the first presentation, endoscopic diagnostic of gastric cancer at early stage, Mr. Tomohiko Moriyama. Всем доброе утро. Я очень рад представить сегодня мою презентацию. Итак, можно запустить мою презентацию. Эта карта уже была показана предыдущим спикером. Мы живем в высокорисковой зоне развития рака желудка, рака на нашей гастроэнтеральной области. В большинстве стран его заболеваемость и распространенность примерно одинаковая, но в Японии и Корее смертность довольно низкая, несмотря на высокую заболеваемость. Можно уменьшить смертность от рака желудочка. Я хочу подчеркнуть важность деления информации между врачами. Это хороший способ определить на раннем этапе рак желудка. Разумеется, это очень важен контроль качества. Но у нас пока нет хороших качественных индикаторов эндоскопии верхнего отдела желудка. Данные взяты из Польши. Почти 6% всех случаев рака желудка упускаются во время эндоскопии. Поэтому эндоскописты должны быть бдительны, чтобы определить на раннем этапе рак желудка во время эндоскопических процедур. Итак, я поговорю о алгоритме скрининга, эндоскопического скрининга. Во-первых, после интубации мы должны промыть слизистую оболочку. И есть очень много слизи на такой поверхности. Мы используем специальные средства включая воду, для того, чтобы избавиться от этой слизи, чтобы добраться. То есть, то есть не будете промывать, не будете обеспечивать раннюю диагностику. Затем, далее мы проводим оценку статуса различных анатомических структур на малой кривизне желудка. А, Мы видим атрофию, интестинальную метаплазию, мы видим липкую слизь. Это вот признаки поражения на раннем этапе, поражения раком желудка. Также мы видим атрофическую границу. После того, как мы обнаружим эту область, мы можем увидеть атрофическую слизь, слизистую оболочку. Также хорошим маркером является светло-синий а, метаплазия кишечника. Итак, на основе этих находок мы можем классифицировать риск развития рака желудка во время эндоскопии. Если у пациента отрицательный H. pylori, то риск низкий. У пациентов с положительным хеликобактером pylorис плюс имеется атрофия и нет интестинальной метаплазии, то риск относительно низкий. Конечно, он выше, чем в предыдущем случае, но когда мы видим также интестинальную метаплазию, тогда риск повышается в несколько раз. Следующее. Мы проводим тщательное обследование всей слизистой оболочки. Мы также должны наполнить желудок максимально. Как и справа вы видите, что мы без наполнения можем пропустить области поражения. Также важно контролировать объем воздуха. Здесь, в таком состоянии, мы пытаемся уменьшить объем воздуха и можем увидеть разницу, границу того или иного нарушения, того или иного повреждения. То есть вы видите, адекватный контроль адекватного наполнения воздухом очень важный фактор в раннем обнаружении признаков рака желудка. Здесь показан процесс для уменьшения так называемых слепых зон. Вы делаете максимальное количество фотографий. Мы можем провести обзор всех фотографий после того, как мы проведем процедуру. Да, мы совершаем ошибки, но за счет большого количества фотографий мы можем провести повторный обзор и провести анализ, почему мы упустили ту или иную патологию, то или иное повреждение. Затем
More. Okay.
свои ошибки, то есть поработать над ошибками. Здесь мы делаем анализ слепых зон. Это задняя стенка тела желудка, малая кривизна, кардии и так далее. И, конечно же, время обследования также очень важно. Среднее время должно быть в районе 7 минут. Далее, на что мы должны обратить внимание? Мы должны быть тщательными по отношению к изменению поверхности, структуры поверхности и цвета поверхности слизистой оболочки. Здесь представлены примеры, находки, которые должны вызывать у вас подозрения. Первое – это изменение небольшое изменение поверхности, изменение цвета, исчезновение сосудистого рисунка и другие. Сейчас мы по ним пройдемся. Здесь представлены признаки. Можете ли вы отметить признаки раннего рака желудка? Здесь мы видим те самые области, которые говорят слева. Наверху мы видим четкое, мы видим погружение. В средней части мы видим одиночную эрозию. Здесь мы должны заподозрить. Конечно, эрозия обычно множественна, но здесь мы видим одиночную эрозию. Поэтому желательно провести биопсию. Справа сверху мы видим дисколорацию, то есть изменение цвета, которое происходит. Слева внизу мы видим красноватую область. В средней, нижней части мы видим уменьшение, нарушение рисунка, сосудистого рисунка. И справа внизу мы видим спонтанное кровотечение из этой области. Как только вы увидите такие находки, лучше провести биопсию для того, чтобы подтвердить диагноз. На что мы должны обращать при изменении цвета? Fujifilm довольно эффективен и полезен. Пунктура может красноватую область сделать более красной, а светлую более светлой. Результаты исследования тандем показывают превосходство LCI по сравнению с белым цветом, белым цветом. Когда мы находим определенные находки, вызывающие у нас сомнения, что мы делаем далее? Мы проводим в Японии, мы используем хромоэндоскопию. Довольно полезный метод. Использовать эндокармин для того, чтобы обнаружить повреждения. Есть 3 области в левой части. Как только мы проведем орошение, ирригацию, мы можем обнаружить все эти 3 области, где мы заподозрили повреждения. Все эти области лечились с помощью ESD. Вот, диагностическая эффективность хромоэндоскопии по сравнению с белым светом. Итак, последний случай. Мы видим спонтанное кровотечение, красноватая область. Мы можем провести предсказания на основе эндоскопических данных. Это типичная картина рака желудка на раннем этапе. Здесь мы видим хорошо демаркационную область с своего рода такой картиной в виде краев, угольчатых краев. Здесь мы видим типичные находки, типичные признаки недифференцированного рака. Мы видим смешанную область с небольшими узелками внутри. И на хроматографии мы видим такие области в виде гребней, в виде скал, таких остроугольных скал. Также мы можем провести увеличительную эндоскопию для подтверждения диагноза. Здесь мы должны сфокусироваться на демаркационную линию. Затем сфокусироваться на васкулярность, на сосудистый рисунок и на поверхность слизистой оболочки. Здесь мы видим правильную, неправильную форму и отсутствующий рисунок слизистой оболочки. Когда мы обращаем внимание на поверхность, мы также должны смотреть на правильность формы, паттерна. За счет комбинации этих картин мы можем сделать определенный вывод о том, является ли это повреждение раком или нет на раннем этапе. Итак, что является здесь раком, а что не является? Здесь мы видим неправильную сосудистую структуру, то есть это признак рака. Что насчет следующего? Это рак или не рак? Мы видим область, такую картину, это тело желудка. Мы видим небольшую демаркационную линию, но видим хороший сосудистый рисунок, поэтому это не рак. Это всего лишь интестинальная метаплазия, кишечная метаплазия. Что лучше, увеличительная АИ или промоэндоскопия? Когда мы говорим о размере повреждения менее 10 мм, то, конечно, чувствительность небольшая. Но когда мы берем маленькие изменения, нам лучше использовать увеличительную эндоскопию. Я не думаю, что это клинически может привести к какой-то сложности, но мы должны обнаружить больше. То есть в больших случаях при большом размере должны обнаруживать их в любом случае для сохранения жизни пациента. Я думаю, хромоэндоскопия больше подходит в таких случаях. Итак, на слайде представлены советы для того, чтобы при проведении такого магнификационного увеличительного метода исследования мы должны обращать внимание на то, чтобы не повредить поверхность и слои структур желудка. На сегодняшний день в большинстве случаев мы проводим эрадикацию Helicobacter pylori. Как обнаружить, как понять, что рак желудка произошел по причине Helicobacter pylori? Здесь мы видим большинство таких случаев дают картину гастрита. Гастрит, мы знаем, что граница нечеткая, и это говорит о том, что присутствует Helicobacter pylori. Вот мы видим повреждения. Даже хромоэндоскопия не может обнаружить границы повреждения. Но когда мы перейдем к другому методу, мы видим границу, мы видим неправильный сосудистый рисунок и также поверхностный паттерн по слизистой оболочке. И это говорит о раке желудка. Как я показал, очень важно обратить внимание на гистологические находки. На раковых клетках есть регенерационная слизистая оболочка, поэтому граница повреждения становится такой неправильной формы. Такие изменения после радикации, такие повреждения уже сложнее обнаружить, поэтому лучше проводить такую визуализационную эндоскопию для того, чтобы обнаружить такие изменения. На сегодняшний день используется и эндоскопия с использованием искусственного интеллекта. Это, по сути, критически важное изменение, но мы также задумываться о цене, а, достоверности и ответственности. Например, то есть автопилотные машины, мы должны быть способны контролировать искусственный интеллект, направлять его. Да, конечно, он даст нам в пользу, но мы должны уметь управлять этим процессом грамотно. Вот здесь представлена стоимость использования ИИ в нашей практике. Мы можем снизить, даже избежать такие данные. То есть вот это нужно, здесь в данном случае нужно было провести биопсию. То есть поэтому вот в таком случае ИИ нам поможет очень значительно. Мы проводим курсы с помощью телемедицины для наших коллег из России каждые несколько месяцев. Если вы заинтересованы, присоединяйтесь к нам, мы проводим такие курсы по эндоскопии. Итак, мои основные посылы. Высококачественная эндоскопия очень важна для скрининга рака желудка, хромоэндоскопия и магнификационная. Есть ли у вас какие-либо вопросы? Большое спасибо, профессор. Вы упомянули минимальном времени обследования для обнаружения рака желудка. Но я думаю, что есть расхождение в теории. Мы в клинической практике, какова ваша рекомендация минимального времени для проведения обследования? И в Японии обычно тратят сколько времени на проведение этого времени? 3 минуты на самом деле слишком мало для того, чтобы обнаружить признаки рака желудка. Я точно не знаю по данному исследованию. Я думаю, 7 минут не включают время промывания. Эти 7 минут не включают время промывания. Особенно для положительных Helicobacter pylori. Очень много слизи на поверхности, поэтому нам потребуется больше времени, чтобы промыть поверхность. Поэтому выделяем 3-5 минут для того, чтобы промыть, и затем проводим процедуру. Когда мы видим метаплазию, здесь мы становимся более бдительными, поэтому уходит где-то 10-15 минут в среднем. Спасибо. 15, да, 10-15. Спасибо большое. Большое спасибо. Сейчас next presentation from Moscow.
Valeria Viktorovna Amirova and Korjova, the new opportunities of endoscopic vision of video system AOHWA. Good afternoon, dear Presidium, colleagues, participants of the forum. For us, it's a great joy and honor to speak at this inspiring city, the capital of Kazakhstan, the city of Astana. Can we launch the presentation? Today, in my speech, I'd like to introduce to you the report devoted to video system from AOHWA company, and I'd like to dwell on the main benefits of this equipment, which makes it a unique choice for numerous institutions. I will cover its technical aspects, which may greatly improve our activity, especially in endoscopy. I'll start with the history of company. Company AOHWA is one of the leading Chinese producers of medical equipment, specializing on production of videoscopes and the adjacent technique. The main focus was on high techs, 3 research and scientific centers in Shanghai, Beijing, and it collaborates with Beijing universities, which allowed it to become the leader on production of endoscopic systems. The mission is qualitative improvement of diagnostic treatment, and geography covers more than 40 countries over the world, including China, Russia, Germany, Japan, and Great Britain. The main trends production of endoscopic video systems, and the company started in 1994, where the company was born in Shanghai. In 2005, they developed the first endoscopic system. In 2013, they launched the model AQ100 with optical improvement of vision. In 2017 and 18, endoscopic system AQ200 with the high resolution vision. The same year, it gets to international markets and exhibitions. In 2019, it envelopes its own production base, and in 2022, Q300 was launched, and in 2024 it opened its affiliation and service centers in Russia, and each historical step had a historical episodes, different awardings and certificates, and great response all over the world. What about Russia? After probation in clinics of our country, the company has recommended itself in Russia, and the confirmation to it is getting large scale, very truthful, just responses from different Russian institutions. What is in store for the company? It invests over 50% of income to development of new high-tech models, such as robotic systems, and getting to the countries of abroad. But what are the key factors of its success? It ensures reliability and optimal range of reliability and quality. Besides, it provides technological innovative approach, high resolution of 4K, function of autofocus, color production, optical increase, mobility, etc. Why is it important for us to understand? Because today doctors endoscopists are not only professional doctors, but professional photographers and videographers. And we need to be able to work on the equipment we work with. And speaking of the models of AQ, the first one, AQ 110, regardless of its seeming simplicity, it has one printer and improved just interface. And the next model, 3 filters, adapted screen, and many other things. Model AQ300, super innovative model, which has multiple benefits. You may see them on the slide. In particular, I will speak of 4K resolution, optical increase, and smart panel, and made the first benefit, resolution 4K in AQ300. Not everybody understands the better resolution is, the better vision we get. In figures, Full HD 1080 pixel and 4K twice as large. Who understands it technically, you may compare the picture of Brad Pitt and see the difference. With 4K, Brad Pitt has a more detailed coverage. Speaking of IQ 200, it's full HD. And here we have the end photo. And you see how detailed and colorful pictures we have with all vessels and pits. Besides, actually, wireless and waterproof equipment, which makes it maximally reliable and lasting. Besides, the nurses would not have the need to include different other equipment. Laser transformation with high speed 8 gigabytes per sec. And this allows for lengthy study, especially operations. Change of endoscopic with one touch, and you may see how easily it is linked with one touch without including processes, and this radically reduces time and very important for high flow endoscopic centers. And you may see how different multiple gadgets can be employed. Promoted system of optical endoscopy. We know that we need to examine all parts of the gastric tract, and in order to differentiate early cancer from intestinal emplasia, or to carry out different diagnostics, or to see intestinal metaplasia, which can rarely be seen in the white light. And the equipment is actually strengthened with coloring of wide spectrum and spectrums of CBI. Aoha CBI, and it includes three modes: regular, indigo, and digo. Indigo at LCI. It makes the white even whiter, the red more red. It provides better resolution. Speaking of model IQ 300, here we get the fourth filter, which allows visualization of vessels. Virtual chromoscopy allows to get clearer vision and qualitative examination. Smart Prome and Mate and DICOM are those benefits which provide different benefits, and this is the storage of different visions, and the May is something like AI, but all this can be covered by Korjeva in her report. And suddenly it includes other benefits of company AOHA, which are the economic models. IQ 200 has digital increase maximally by 2 times. And here you may see 1.2 times. Though there is no cap, still the resolution is being provided with all detailed just picture of the mucosal layer. And it also allows 100 times increase the mode of double display, which is very important for us when we work and when we, during training, demonstrate in two pictures. The design is more economic, the heads are very comfortable. The block of management includes the high spectrum balance of the white light and many other things. And all tuning which are important can be personalized for the user. The blocks of management has the regulated lighting and automatically it passes to the required mode and if needed we can include CO2 and let me introduce our own experience of video system Aloha in endoscope of the stomach tract. We performed 365 endoscopic studies, 299 were diagnostics, and 66 were surgical. One clinical case, the first patient E, 47 years of age, with the diagnosis autoimmune gastritis, diabetes of the first type, endocrinic tumor, and due to which we performed the lifting. Can we launch the second vision? I cannot launch it. How much time do you need? 3 minutes. We performed lifting, which was full circular resection of the mucosal with the use of the soup with local mode. We obtained neuroendocrinic tumor and the same patient in antral part of the stomach. We detected this tumor on short leg with biopsy with the drawing which was resected. The third case, more demonstrative of character, patient 10, 52 years, in regard to the vertical, for the verticulectomy, and you see how good is the pictures, no problem we had. Just we want to pay your attention that distal part of the apparatus with diameter 9.6 millimeters and the cup can be fixed very strictly. Then if we speak of the leading facilities, that's the fourth clinical case. Patient L, 39 years. Leaching was done successfully. And in conclusion, I want to say that the equipment AOHWA provides unique opportunities for endoscopists striving for high quality of work, innovation, and accessibility. In conclusion, I'd like to say that beauty is in the eyes of the looker, Oscar Wilde. And with this kind of equipment, you always will be capable to see the beauty. Thank you very much. Now we'll proceed the next speaker, the use of low profile shishin. Good afternoon. We wanted to share with you the accumulated experience of use of gastrostoma in clinical practice. Yes, we frequently come to the situation when in stationary we need to use gastrostoma, which is some surgical option with creation of artificial entrance to the stomach through the esophagus with the purpose of feeding the patients in parallel way. Indications are different, including surgical, and in summary, whatever allows to get food in parallel way. Gastrostomia has numerous implications, surgical methods, endoscopic methods, and certainly comparing the surgical and endoscopics, surgical, well, is different due to its high trauma factor, risk of incapability, problems of estate, regenerative capacity, and endoscopic is less invasive, reliable, uh, weak feeding, and comfort for the patient. There are some anti-indications, but if we need to establish feeding not in parallel way, we can use neutral feeding, and it is done through clinical opportunities of the patient. The options of endoscopic gastrostoma are different. There are 524 where actually the whole system is captured, and from the food pipe it gets externally, and the push technology, when we put the gastrostoma under control of the advanced part of stomach, not through the food pipe. Uh, a little bit more complex technique, but as practice shows, this type of gastrostoma has certain priority. I would say why. The methodology seems simpler, and we put gastrostoma and bumper in the pathway of the stomach, the movable part of which external antibumper, and by comparing and locating an antibumper later, gastrostoma may be adapted for any just width of the gastric wall. But there are certain anti-indications with the tumor defection when it is impossible to conduct to be conducted due to stenosis, uh, problems with introduction in the post-operational period, availability of the bumper syndromes, excessive compression of bumpers, and whatever is in the stomach, it is more sensitive, and it can get to the width of the wall of stomach, and the need for replacement, and the problem of replacement of a tube with the patient who has lengthy forecast of life. It brings to the situation when they need lengthy feeding, and changing such simple system technically would not be easy. And if people, due to oncological process, availability of additional tube causes certain discomfort in life and some psychological problems. This is typical bumper syndrome when we see that bumper is getting deeper under the mucosal layer, and mucosa covered it and covered the pathway. In this situation, we could just try to pick it, but the effect of the acidity makes bumper much stricter, and it cannot be just seized. But another technology, when we push through this section of the mucosal layer with aggressive knife of open type, we just dissected this layer, and thanks to that, bumper could be localized to the passage of the stomach, and with the help of endoscopic tools, because through the channel it could not be removed because of its strict form. There were certain efforts we managed to capture this internal part, and with good efforts take it out to the pathway of the stomach. Then it all is resected. Push methodology does not require its taking through the food pipe and easy replacement. And the main thing that low profile control ensures good control for the patient. We fix a part of the frontier part of the stomach, and it's taken to the abdominal part, and it is done in punction mode through an endoscope. We select the place for gastrostoma location and the part of the stomach with the balloon then budget is done, and it's very important that it should be filled with water, and gastrostoma can get out. It's not just terrible, but better to be avoided. And with the help of the needle, we can avoid it. And this platform, we have 4 puncture layers, and the needle is introduced as soft conductor, and the system bourgeonnage of certain diameter where the length of gastrostoma is detected, and there is a stage step-by-step line, and we can use the measuring balloon. Now it will be introduced, which has certain demarcations, and externally we can assess the required tube, and then the balloon is withdrawn, and further on the tube has the effect of dissolution, and then by its channel we introduce the passage of gastrostoma. And actually, this balloon is the key part which allows to perform replacement of gastrostomach tube, which is so important. Then the balloon is reduced and the tube is not dangerous. It can be withdrawn easily. In average, from profile gastroma, it takes from 3 to 6 months, and then under the acidic factor and getting more fixed, it can be easily just located there without discomfort. Aseptic after operation, we should have aseptic cover, and then feeding should be done for the next days, and treatment in the sphere of replacement should be performed. Now the experience is greater. We have about 200 patients of different age without serious complications in its installation, but there are some complexities due to the initial time when they should be fully examined. If there is gastrostase event, there are certain aspiration and other tubes. Technologically, it's the same, but then we need to introduce this tube, and then the color 6, but there is difference in selection of tail, and this should be very acutely approached.
One small question, practical. How often, or does it depend on a person or features of the tube? How often do you change it? It depends on the tube itself. It's a very good question. In multi-specialty hospitals, so there are more patients that due to certain lack of the status, they live for a long time before they gain weight. So if the tube is functional, you may you might not need to change it, but after 3 months you will have to see how good it is. So if the canal is already there, how the cuff responds to its filling, inflation and deflation, and so depending on that, you will decide whether to change it or not. Also, depending on the weight gain, if there is a person is gaining weight, then there will be more. It is more likely that you will change the length, the tube, to make it more long, to make it longer. If you would like to have a snack after this session, we'll have lunch. So those of you who are hungry, you can go to the tea and coffee tables and get some treat. Next presentation, modern possibilities of peroral transpapillary cholangioscopy in the diagnosis and treatment of hepatobiliary pathology. Mr. Budzinski, let's give him a hand of applause. Good afternoon, dear friends, dear colleagues. Indeed, in the past few years, no large forum goes without discussing the transpapillary cholangioscopy, peroral cholangioscopy. This is a fast progressing technique that is being used around the world. This year, it's turning 50 years when colonoscopy was first conducted in 1975. Olympus offered it for the first time. First, it was used for diagnostic purposes. In 90s, the range of its use widened, extended due to gastroscopes. They can be used to get into the lumen of the hepatobiliary system and the pancreas. At this point, so in the middle of 2000s, they started to be widely used in clinical practice. Spyglass scientific. If we talk about the diagnostic possibilities, then it is first for visual assessment and for also to take a material for further histologic study. And next is for choledocholitis revise to examine biliary ducts for those patients who cannot be conducted X-ray, and to diagnose different rare pathologies for hemophilia, parasite lesions, and so on. Can we play the video? It would be a pity if we cannot play the videos because there are many of them. The previous slide. So the second, the third on the right should be playing. We should be able to play them. That is sad. For many years, radiology methods were prevalent, so it was not a problematic to find the localization, but the genesis was very problematic. And with the appearance of colonoscopy, this became possible, and this got to a new level. There is a number of benign and non-benign lesions. Only in visual assessment, in 90% of cases, you can give an exact, precise diagnosis that will be confirmed by morphology after taking the biopsy. If we compare the possibilities of sampling a material and assessing it when you take a biopsy for during X-ray and visual colonoscopy, you can see that for main parameters for sensitivity, false negatives, negative, the visual nature is more prevailing, is more advantageous. There are a few important factors when you do perioral colonoscopy, gives you more precise diagnosis and allows you to uh, assess the length and the markedness of the lesion. And the third one, almost third of patients have the opportunity to change the tactics, which is critical and crucial. Verification of the complex cholelithiasis or severe cholelithiasis. First, it was the concurrence of the cyst duct and its stump. It's the intrahepatic cholelithiasis and identification of the recurrent cholelithiasis in patients after the operation on the biliary tract. Without the video, we are losing quite a bit of information. So here there was a capsule of the echinococ cyst. Can we try to play the video here? Practically, this remained a blind zone. Using cholangioscopy, we can determine whether it is a epithelial or cholangioectasia or or ductal ductal cyst. And now regarding the therapeutic cholangioscopy, there is a wide range of indications. Those are different types of political lithiasis. When you conduct a contact intraductal lithotripsy, uh, therapeutic interventions in the Merisi syndrome, removal of biliary stones under visual control, and when you remove epithelial formations, this is a very promising direction. Some formations can be removed under visual control. The basic point is that severe cholelithiasis, there were two modalities, hydraulic lithotripsy and laser lithotripsy. They had the same values, both for frequency and the complications. So the European Society for Gastrointestinal Endoscopy use both of these methods as comparatively same, depending on what the hospital has handy. The main one was the uh, intraductal lithotripsy in treating severe polydiclolithiasis. So ESG recommends to use contact methods of lithotripsy when you encounter severe polydiclolithiasis, and the other one can be used for traditional cases. In 2013, for the first time, they offered to the medical society, to urologists, a new method for laser lithotripsy. That is that special fiber-based laser, super impulsed fibro optic Thule laser. It was used for the first time successfully for lithiasis, and both in Russia and in other countries. They started to use it more widely. A very interesting direction is the treatment of the biliary cyst. For now, and now with the appearance of new methods, new techniques, small biliary cyst, these patients could be treated endoscopically. This is our experience, 18 patients. So there were two stages. One of the patients had a big stone. You can see that in 18 patients, so we were able to provide a full sanation, 42 months of follow-up. There was no recurrence of polydiclolithiasis and the stones in the gallbladder. Next case is the removal of concrements and their fragments in conducting peroral intraductal interventions with visual control. when a patient has an allergy to a contrast agent, when you cannot do traditional technique, there is a whole range of patients with foreign bodies. Such patients can be the causes, such things can be the causes of recurrent cholelithiasis. In the majority of cases, we are able to remove them. Even the best state-of-the-art technologies help us go through narrow strictures. So when we do perirolar transpapillary cholangioscopy, we are able to go through such small strictures. Radio frequency ablation, and this is not a new method, but in the past 7 to 10 years, and in several years in Russia, it started to be widely used. Those are strictures. We are able to recanalize them, and it gives good results. The second one is to canalization the metallic stents. The third one is adenoma in the ductal system. And there are publications on the use of radioablation in benign biliary strictures. Photodynamic therapy is also a beneficial and interesting area. Under X-ray, you define certain lesion and use this method and then conduct assessment after this. Removal of foreign bodies and then removal of epithelial formations using forceps or loops. And this looks like removal of whole polyps. Complications of peroral cholangioscopy. You see the frequency 7% does not exceed the statistical average statistical complications for other methods. So we conducted these studies. We conducted over 500 cholangioscopies in the period since 2017. The main indications are strictures and cholelithiasis. Next, about 10% are foreign bodies. The effectiveness of all the interventions was 87%. Sorry, 96%. When we visualize the structures, relative cholelithiasis is 96% is a significant value. As I said, in 90% of cases, we were able to use it for the Berriasi syndrome. For cholelithiasis, it was effective in 82% of cases and 83. With under X-ray, we were able to provide to treat these patients. And epithelial formations and radiofrequency ablation is only gaining momentum, but it is becoming significant. Complications, as in literature, it is 3.5%. Mortality, 3 cases due to retrograde interventions. In conclusion, I would like to say that the main indications for endoscopic perorolar biliary interventions are undifferentiated or complex strictures of the biliary tract, severe cholelithiasis, and foreign bodies. The results that we obtained correlate with the statistics, with the literature that speak to the high effectiveness of this method. And also important is the use of new techniques, new technologies. There is a overestimation of tactical methods in the treatment of the biliary tract. There is a growing number of opportunities to treat severe patients. What earlier it was considered to be hard to diagnose such patients, but now they become a reality. We can can quite effectively diagnose and treat such severe patients. Thank you very much for this interesting presentation. We are actively implementing this procedure. If you have any questions, please ask those while the doctor is here, when you don't have to call him while he's doing a procedure. Thank you very much for also to keeping the time limit. Next presentation, Mr. Sikerbekov, endoscopic treatment of chronic pancreatitis complicated with hypertension of the pancreatic duct. Before we start, good afternoon, dear colleagues, dear friends. Allow me to present to you endoscopic treatment of chronic pancreatitis complicated with hypertension in the pancreatic duct. Thank you very much for giving me this floor. And today, chronic pancreatitis.
Today, the chronic pancreatitis is the disease. The symptoms are strong pain, which affects the quality of life of the patient. And it also is accompanied with the structure of the endocrinic and exocrinic insufficiency. And today, the surgical and endoscopic practice is important and is regarded as new methods of endoscopic. And the pancreatic passage is the main way, and the literature speaks of the good benefits and insufficiency. But as of today, there is no algorithm of treatment method. And the main causes and the goal of our treatment is easing the pain from disease of pancreatic. But the main cause of appearance of the pain syndrome is hypertension of the main passage of the system of pancreatic system in 85%. And the causes are ischemia of parenchyma and also stricture of the main pathway and hypertension and cysts of pancreas. And this study has 30 years, but it's still very topical because the clinical classification can be divided into two types. Type A, acute recurrent pancreatitis, and type B is chronic pancreatitis with permanent pain from months to 2 years. And probability of lack of recurrency performed by surgical and non-surgical treatment ways in two groups for over 10 years since the moment of the start of the pain. We would not dwell on classification because domestic and foreign authors are trying to select different forms with chronic pancreatitis, and this led to a great number of different classifications, but they can be subdivided into four main groups. The first table demonstrates our Finnish colleagues with cysts of chronic pancreas. With cyst, we do not perform endoscopic intervention. With lack of pain, the endoscopic creaming is done. And accordingly, with pseudocysts, the approach is similar with performed transmural creaming. This is an old classification of Kremer. Not all pancreatitis are subject to such interference. As to the gastroenteral, the calculus in 60 or 22% allocated at the head, and the average number reaches 10 millimeters. According to ESG data, it is recommended to perform high quality computer tomography to exclude the cancer of pancreas. As it has been said and confirmed by ESG, the LVL ESDG is the first method of the main treatment of such cases. In 98% of cases, treatment is successful and concrements are regulated. And Chinese colleagues have performed systemic reviews on 214 patients with electric wave detection and up to 97%, and their fragments for 4% with versatile approach, lowering by 36%. According to ESG, electric wave approach should be done in case of less than 5 millimeters. Not always there is opportunity of availability of electrowave dyspepsia and electric trypsia, but this does not deny the need to take endoscopic approach, and for this there are certain conditions. If technically it is not feasible, then we may perform this methodology, and mandatory is fulfillment versalotomy with approach of less millimeters. Endoscopic treatment of stricture of chief pancreatic passage. We all know this procedure, the mandatory condition, technical algorithm of fulfilling this treatment. And papilla and sphincter papillotomy with complex oblastic access and mandatory plasts, availability of phalangitis, and expansion of the passage up to 12 millimeters. And processing with several stenting approach, and the size of plastic stent leads to increased number of hospitalization due to the plant incrustation. And individual the tactics of finalization of treatment is the use of contrast dissolution for over 2 minutes and the uh, introduction of instruments. And opportunities of self-expanding video structures are not as large as introduction of thrust motor watergenesis. According to data of global literature, as a result of controlled study of 100 patients for the 2 years after conclusion of endoscopic treatment, after the withdrawal of stent, there was no pain syndrome. Pancreatic stenting with strictures actually are technically feasible in 96 cases, 86% in early periods. According to global literature, complications for trans interventions up to 36%, typical complications, post-manipulatory pancreatitic involvements and retroperformal preparations and stent-induced complications, migration and early incrustation. Endoscopic treatment on the basis of global literature, the most frequent change is availability of strictures, and endoscopic intervention can be done through the lower part of the pancreas. And according to different studies, up to 87% of cases, all specialists. Can you switch the video, the previous slide? Specialists just quote to be extremely cautious because this invasion can lead to post-operational pancreatitis. And this methodology can be used for research purposes and after multidisciplinary studies. As you may see, this is fulfillment of endoscopic drainage with similar done through the chief pancreatic passage, but the complication is acute post-pancreatic complication. The ways of treatment, pancreatic gastroanastomos, and under control of method of rendezvous. Indications for draining can be the early fulfilled surgical interventions or rough deformation in different parts, also technical inaccessibility for the diagonal part, endoscopic access is retrograde access and gastropancreatic through the wall of the stomach and under control of radiography. And again, the global literature speaks of successful performance of such methods for 30 years. And the reason of employment of this methodology is technically inaccessibility. And complications can lead to perforation and stenting. Technical successes are very just promising. And stages of drainage under control of method of rendezvous. And we select the on the vascular zone with a very thin needle. We get the retrovaginal passage to an endoscope and push it for further orientation and retrovaginal. We stent the main passage, which is called method of rendezvous. Similar method with thin needle puncture and the passage is expanded to 10 millimeters. The fibrosis change of the pancreas is located. And further on, with the contrast solution, we get the strain to the zone of express stricture. And we do artificial savusty. And further on through the strain, we stand with one pigtail of the chief passage. Again, according to global literature, 222 patients were registered, and the efficiency achieved 77% of performed operations. Now, the method of selection of endoscopic treatment of pancreas is done with the endoscopic and X-ray control. And the size of pseudocyst over 5 centimeters and with dynamic observation according to global literature, positive development of pseudocyst fully disappear and some recurrences not exceed 16%. 87% with endoscopic treatment did not have complications. Similar results. Mortality is considerably lower. And main technical peculiar features are availability of cysts in the upper parts, which allows without control, and transmural drainage can be accompanied with control transpopular performance, and gastrostomy and cystostomy can have remote results. Transmural drainage is done minimally through staging 2 stents. And performance of drainage is done with similar method with the help of thin needle and puncture. And after drainage, visualization of limited cases. And the next slide, through transpopular drainage of cyst. And the condition when pancreatic segment forms some liquid formation, and for long we could not get to the passage because of the pseudocyst. Unfortunately, there is no photo fixation, and the conduct of strain and the liquid formation. Well, colleagues speak of the positive dynamics of the patient. Complications, transpopular interventions, we always can perform and control endoscopic way. Well, time is over. Options for insufficient drainage of cyst, changing the location of the stent, and 2-stage drainage after 3 or 4 days, leading the patient before and after stenting. They all were actually under control of different tomography, and after procedure, drainage was done during 12 months, and sanation was done every 6 months. Each patient had before and after magnetic resonance tomography, which allowed decrease of the passage, and the procedure actually allowed to decrease the passage from 9 millimeters to 5 millimeters, and chronic pancreatitis lowered by 50 grades. These are our results, not including pseudocyst of chronic pancreatitis. In conclusion, this method is a technically complex procedure, but physiologically it is less invasive and more preferable. Thank you.
Thank you very much. This amazing presentation. I have a lot of questions, but I'm going to ask it later. If you have any questions, let's ask those. Risks and complications in what endoscopy? I mentioned 5 to 6 types. Structures, in structures, the strictures are high, but we do, according to world literature, the value is high in chronic pancreatitis. Pancreas, it doesn't respond too often to most post manipulation pancreatitis. To me, I don't know why the percentage is too high. When we stent, the pancreatic parenchyma is changed, there is a hypertension of the pancreatic ductus, and the probability of the pancreatitis after that, after the procedure, goes down. This is according to world literature. Thank you very much. And the final presentation of today's session, our co-chairperson, Indira Kamitova, with associated new releases of the celiac ganglia. Thank you very much. So, abdominal pain syndrome is not quite common, but it does take place. It does happen. Where can I navigate it? Chronic abdominal pain syndrome is commonly seen in patients that have either tumor, intractable pancreatic tumor after operation, or chronic pancreatitis. Such patients, if they have a hard time, they are always on painkillers that don't quite help. What is neurolysis? That is, or neurolysis of the celiac ganglia is when these celiac ganglia, irrespective of the way, are blocked. Let's start with contraindications. Is that when the general condition of the patient is severe, marked coagulation disturbance, certain anatomical peculiarities, when you cannot put an endoscope through the lumen, certain technical points, a lack of the needle, or certain legal difficulties. What other types of neurolysis under ultrasound or CT through the transdermally, intradermally, intralaparoscopic, and intraoperative, and endoscopic through under the control of ultrasonography? What are the advantages? Is a clear visualization of vascular structures, minimal distance from the distal part of the echo endoscope to the celiac trunk, absence of the risks of paraplegia in pneumothorax, and radiation exposure to the patient and the doctor. We use a linear echo endoscope and endo ultrasound equipment. This is one of our patients when we just started to conduct it. If I may, can I pinpoint using the laser? So here we can see that on the endoscopy, we can see the celiac trunk, the upper celiac artery, and our ganglia are here. So the main part of providing correct neurolysis is to measure the distance from the needle to the ganglia. This is important, this is crucial in order not to affect one of the vessels. Such patients don't have too much fat, so the distance is small. So here on ultrasound, you can see this clearly. You can visualize it clearly, and that's the advantage. We did not conduct pathological studies. there is a fibrosis around neural lysis. This is what we aim to in order to get the blockage of the ganglia and to block the pain. In our experience, for within 3 years, we had 6 patients and 10 procedures. They were males predominantly. Those had pancreatic cancer and pseudotumorosis pancreatitis. The method is that periodically this procedure neurologist doesn't help starting for the first starting from the first procedure. We provide repeat procedures. We use 98% alcohol. We try to get into the ganglia when visualization goes down due to too much fluid. So getting the medication into that area also plays a role. It provides its effect. In one patient, had an amazing effect after 2 hours. He couldn't eat, he couldn't drink, but after our procedure, after 2 hours, he could drink and eat, and he was very happy as we were. Other patients, the the effect was after the second procedure, and one patient with chronic pancreatitis pain unfortunately didn't go away. They did go subside, but they came back after 2 weeks. What are the complications? They are common ones, general ones, related to the echo endoscope. For example, perforation of the sinus, perforation, bleeding, aspiration, or complications related to medication, sedation. We use propofol narcosis. Some people do narcosis or intubation, but over time, people move away from it. Specific complications that have to do with the procedure, hypotony, diarrhea for short time, peripancreatic abscesses, and pain syndrome and gastroparesis. We didn't have such complications in our small group of patients. Our patients had a very positive outcome. As a result, I would like to say that in our country, we actively implement endosonography. In several cities, we have implemented and trained doctors. And I believe that by implementing this method, we will be able to help patients improve their lives and get rid of the pain syndrome at one point. And the second point is economical. Nobody buys some medications that they take or plasters. So the economic uh, impact is also there, and the social effect is also there. If there are such patients that need that require such intervention, you could refer them to our center. We will be happy to cooperate. Thank you very much. Are there any questions from the audience, or do you all want to go to lunch? Since this is a young procedure, that there will be fewer questions, I guess. But no, there seems to be one question. Hello, everybody. I has had a patient. I'm an ultrasound doctor. You said to refer patients to you. Patients ask, there is such a antibiotic bleomycin. In China, it's used for sclerotherapy. And they sent such patients to China. So they use this antibiotic, bleomycin, for to pa- to kill the pain. Can you tell me the information? I don't know how they do it in China. You mean they do neurolysis? They use it for neurolysis and for capillary hemangiomas of the liver. We don't use an antibiotic because alcohol and anesthetic do their job very well. So there is no need to make it costly, to make it more expensive. But in terms of price, alcohol is very cheap. It's available everywhere. So I don't know the price, the price of the antibiotic, but alcohol is very cheap. Thank you very much. Now we will have a break till 2 o'clock, 2 p.m. I would like to say that we will have lunch in Sarka. So there will be tables for speakers, standalone tables.
получаем мануальный анализ, у себя на рабочих местах. База, которая есть на сегодняшний день, и много привлекает сюда еще.
Есть возможность отработать навыки те же самые вот диссекции на живых свиньях, которые заинтубированы и находятся под эндотериальным наркозом. И под руководством экспертов, приглашенных из Москвы, из Петербурга, из других городов России, можно отработать навыки эндоскопической посредством диссекции и других методик. Я бы рекомендовал этот курс специалистам, которые хотят заняться оперативной эндоскопией.
Коллеги, мы начнем. Попрошу, ребят, попрошу двери закрыть, пригласить всех оставшихся в зал. Наша секция посвящена нижним отделам желудочно-кишечного тракта.
So the first report is devoted to electric surgery with endoscopic operations at large intestine, Midrakov, the head of the course of endoscopy, Nizhny Novgorod. Good afternoon, dear friends. Thank you for my presentation. I am for the first time in Kazakhstan. I am happy to be here. I'd like to thank the organizing committee and its manager and the company for tech. So and the company for tech for the opportunity to arrive here and for the opportunity to meet colleagues. But the notebook does not move. Can I list my files, please? Help me. So my city corresponds to this section. I represent Nizhny Novgorod. And one of the aspects of our activity is training of doctors endoscopists, and the focus is on endoscopy with teaching to the mode of electric surgery, and this is one of our priorities. And when we say of the need of electric equipment, we pay special attention to availability of good electrotechnical block. What does it mean for endoscopists? The main thing that there should be available special mode adapted for flexible endoscopy. But when we speak of such modes, we understand that it has two pads, yellow and orange. The yellow pad, as a rule, endoscopic mode implies mixture of two methods, coagulation and cutting. And our task with operation is to preserve the balance between them. If there would be too many coagulations, and there can be very bad mixture, and vice versa. In the other case, there can be bleeding, hemorrhage. Speaking of the parameters which we can tune, uh, these are three major. That's the effect of cutting and the length of the impulses of cutting. The second is coagulation and the frequency of impulses of cutting, how frequently they would be provided. Let's start with the first parameter, effect of cutting. We may see from top to bottom increase of the width of the yellow column. That's the time for one interval of cutting. The higher, the longer is cutting. The second is the plateau. The high effect of coagulation, more coagulation is done by the equipment with pushing the yellow pad, and the frequency of supply of impulses while cutting. When it is done with cutting of mucosal cover. With work at large intestine, we start with cutting, and depending on the instrument, whether a knife or a stitch. And here we introduce modes. The block, there are 4 modes. Mode force sharp, the so-called quick mode. It's comfortable for small bleeding of small vessels. It can be done with a stitch use, but a massive instrument can be employed, but coagulation does not penetrate deeply to the wall of the intestine. Soft coagulation, that is long, deep in tissue, it requires more massive instruments, graspers, forceps, and the mode spray is used for the use of tunnels for submucous membrane. When we need to cut off the formation, what factors impact the selection of the mode? We will select that mode. Localization also impacts the selection of the mode. And what is important if we are talking of larger, it's important to know whether we have pedicle or not. For example, here we present tuning different. First is if attack, which we employ in our practice with my department. If we do resection, if it is left or right mode, in left modes the effect of coagulation will be higher, in the right coagulation would be lower. If the profactor error in the cut effect too. These are my tunings, but while traveling in different departments, I tried to find the ideal tunings. But in the course of time, I realized that they do not exist because each doctor has its own specificity, his own just preferences, etc. And coagulation, soft regulation, allows, in case of need, to perform hemostasis. If a polyp has a pedicle, if there is pedicle, there are major vessels. But if we the risk of bleeding is not high, then the pedicle would be squeezed, and in any case, it will be one. But when we talk of dissection of submucosal layer, there should be resection of 2 programs. At this slide, left pictures illustrate when we use dissection of the mucosal layer combining with soft coagulation, and we see a vessel. We take the required instrument and perform hemostasis. And on the third dissection of submucosal layer. But if we see swift coagulation or figure, and I would like to give a number of cases. That's the example of adenoma in this large intestine, and this method safe and effective. In such cases, we would not even switch it. On this video, we are doing resection of the polyp from the pedicle, and without adrenaline, we put the stitch and the mode of coagulation is high. We see a small vessel. We do not get strong hemorrhage here, happily, and we use hot biopsy and soft coagulation. Coagulation has been performed, operation has been finalized. The next example, it's interesting from the point of view of diagnostics. Young male with polyp at lower part of large intestine, adenoma of low degree. We understand that when we talk of this localization, we are very attentive, especially attentive to see what we have in place. And here we show the stage of diagnostics with the help of cup. I take the polyp to the side and we see Genet 2A. And here we take polyp to the side, switch on BLI mode. And you can see well the mode 2B. That is the early cancer of large intestine. And now we start thinking how to perform maximally radical operation for this patient. And here we should note how useful it is to observe and analyze what we see. And here we see the lack of invasion. After that, I open the stitch and try to see how well I can grab this tumor. If I do not use the stitch, then with the end of the stitch, I do dissection of the cover, and it has high frequency of cutting. We see how the end of the stitch moves, effect 1 for this cutting. And the cutting has been performed. We add solution, then we turn it over and I switch off the mode to the mode of stitch resection. And here we will have the second or third effect. and because we would not be afraid of perforation and understand that vessels would be large. All this is done quickly. I do not get distracted to buttons. The location on the wall allows us good visualization, and here we need soft coagulation in order to grab them with hot biopsy, and we perform coagulation. This section in submucosal layer, the first program allows dissection of the first layer, high frequency of cutting, effect of coagulation low. And when we see major vessel, we need to grasp it. And with the soft coagulation mode, we need getting to cutting the submucosal layer, and depending whether we have vessels or not, we may perform dissection in submucosal layer. I'd like to mention such clinical case. It happened 9 years ago with polyp of intestinal carcinoma. This case has changed my personal approach of removal of pedicle. First of all, I practically always use solution for dissection of pedicle and see what I received. I did not see it, but I saw it when I had complication. We get to the wall of the intestine, and at that moment I saw that tissue has whitened, and we kept the patient in stationary for 3 days, and on the 4th day she had perforation. Unfortunately, everything was safe, but she periodically gets through colonoscopy control. But I mentioned this incident for you to understand that you need to check electrode location frequently. So first of all, we need to know the work with the surgical block, and for performance of high technological endoscopy, this block should be done very attentively. In conclusion, I want to share with you some courses, invite you to our Nizhny Novgorod. Please give the sound. This is one of the courses we conduct. It's devoted to the section of bottom layer. We get those skills, practical advice that we would introduce in our routine activities. This is a unique base in Nizhny Novgorod. And these manual skills, we have a laboratory. This is besides, we have the opportunity to work over the skills of this section and under the management of experts from Moscow and other centers. we perform endoscopy of different methods. I would recommend this course for specialist endoscopists. To get such experience is very complex, but we managed to strengthen our theoretical and practical knowledge, and we're very happy to be in this beautiful city, excellent team of specialists, and we would like to say many thanks to Alexander Anatolievich for the knowledge, for information, and beautiful people, beautiful information. Thank you. We would like to invite you to us. We get courses, provide courses almost every month. There is a reference to our site, to our Telegram channel, where you may check the topical information. Thank you for your attention. I wish good health to your patients, to your relatives, and to you. We have questions from Professor Hiroshi Kashimeda.
I clearly remember the days I visited you 5 years ago, just before the COVID. You talked about the bleeding after endoscopic resection, and you use hot biopsy forceps for that. Is that a reusable one or a one single-use hemostatic forceps?
Thank you for your question, Kashida Sensei. Of course, normally we have to use it just once. Of course, it's single-used forceps. If we speak about co-grasper, if we speak about Boston Scientific forceps.
Yeah, actually, hemostatic forceps are very expensive. And for colorectal ESD, I actually use hot biopsy forceps that is a reusable one because I don't encounter many severe bleeding after colorectal ESD. So I use reusable hot biopsy forceps.
Sorry, who makes these forceps? Which company?
Olympus.
Olympus.
Traditional hot biopsy forceps. I don't use it for removal of the polyp, but only for the hemostasis during ESD. And another point is coagulation can be expensive, but also can be dangerous. So why don't you use hemostatic clips, hemoclips, for bleeding right after the polypectomy?
Sometimes we use hemostatic clips, but not so often. Maybe for me, it's not the first choice. Usually, I start with hot biopsy forceps. If I do not have success, then I usually use hemostatic clips. For some reasons, maybe one of these is because if we do not have success with the clip, sometimes we have to remove it, and after that we could have more severe bleeding than it was before. But it's maybe only my way in my hands. I do not think everybody. Maybe for somebody, it is better to use hemostatic clips as the first choice.
Yeah, they are a lot less expensive, definitely cheaper than hemostatic forceps.
In Russian market, hot biopsy forceps are cheaper than hemostatic clips.
Oh, is that right?
Yes.
I didn't know that. Okay.
I think about 2 or 3 times cheaper. That's why we prefer hemostatic hot biopsy forceps. Александр тоже, спасибо большое. Спасибо.
Thank you, Alexander Anatolievich, very much.
And the next speaker, Professor Chon Sonu from Daegu. And his topic is various instruments and techniques for endoscopy submucosal dissection. Johnson Wu, PhD professor, School of Medicine, Kyunpyuk National University, Chuguk Hospital, Daegu, Korea. Please.
Thank you, Mr. Chairman, for kind introduction. I'd like to talk about various kinds of instruments and various techniques for the endoscopic submucosal dissection, especially focusing on the colonic ESD. Okay, this is my COI. As you know, endoscopic submucosal dissection has several advantages like embolic resection, and if it regardless of the shape and size. However, it needs multiple steps for the complete resection, and during the procedure, we need many instruments like this knife, injector, hemostatic devices. First, there are several kinds of endoscopic knives in the market, and we can simply divide these endoscopic knives into two classes. The first one is a ball-tipped knife. It's an insulated type. The second group is a needle type, shown in the right side of picture. And for the ball-tipped knife, it has an advantage for the rapid and safe procedure because it has a ceramic insulated tip. And it is also easy to handle. However, it's not possible, not suitable for the fibrotomies because it has weak lateral cutting performance. On the contrary, on the right side, the needle type, it needs the control of a direction, especially for the hook knife. So it makes a precise and gentle procedure. However, it needs expert assistance to rotate the knife and also accompanies some risk of perforation during procedure. So for the colonic ESD, usually we use this kind of instruments. First one is J knife, like dual knife from Olympus, and also a hybrid knife. I will introduce this knife in the later part of my presentation, and we need hemostatic devices. For the colonic ESD, needle knife is useful. It has various specs from the diameter and I mean the length of the knife from 1 millimeter to 3 millimeter. In it, and the knife tip is it acts as a hook, so you can dissect the submucosal layer after hooking the submucosal layer like this. And this J knife was evolved to J plus knife. And as you can see, this picture, this video, it makes fine dissection and it has a round surface for the coagulation in the case of bleeding. And also it is suitable for the fibrotropism. And it has a water jet function, so you can inject some saline with exchange to injection, etc., directly to the submucosal layer. Okay. In this video, in the left side, with the stomach, during the gastric ESD, you can direct inject saline with J plus knife, and also during the submucosal dissection, you can use this knife as an injector. So it facilitates the speed of the procedure, I think. Also, we recently launched a hybrid knife, or also a mini knife. In left side, this is mini knife. The right side is Olympus mini knife. And during the colonic ESD and also stomach ESD, we can use this kind of knife for the rapid procedure. And also CAP is very important instrument for the ESD because it can lift the mucosa flap and make good visual field during the procedure. There are different kinds of type in the market. The first one is a straight one, and second one is a conical one, conical type. And with conical type, with a small mucosal incision, you can easily get into the submucosal layer. So it is very efficient and convenient for the endoscopist when doing the colonic ESD. There are commercialized mucosal solution also in the market, and the representative one is hyaluronic acid, and it is available also in this country, I think. However, it's expensive, so I usually use normal saline for the mucosal solution for the ESD mixed with adrenaline, I mean epinephrine. From now on, I'd like to introduce some basic principle steps for the colonic ESD. However, I think it might be some overlap with the next speaker, so I quickly look over my presentation. The first step is identification of lesion and establishment of resection plan. For the instance, rectum has a high vascular structure, so the bleeding tendency is high comparing to other side. And for the ascending colon, there is a limitation of endoscopic maneuverment. So it accompanies a high risk of perforation, this lesion. And you have to use gravity in performing ESD. The second step is mucosa injection. In this step, it's important to avoid perpendicular direction. And we usually start from the anal side, and after then, make a mucosal incision like this. Usually, it's better to make some distance from the region, usually from the 5 to 10 millimeter apart from the region. That's why, because if you start too close to the region, it's difficult to expose the submucosal layer. And in the case of submucosal fibrosis, it is better to have more distance from the lesion. And another important point is that don't make a circumferential incision fully in the colonic ESD. We usually make a mucosal incision about a third or a fourth of diameter, like this. If you perform the circumferential incision on the right side, usually submucosal injectator solution usually washed out, so it makes difficult to further dissect the submucosal layer. And the first step is trimming. It's a repeated dissection of a superficial layer of submucosa, like this. After movement to left to right to left, conical cap, you can create pockets for the submucosal dissection. And it is important. Many experts recommend to keep the submucosal dissection layer keep to the half or a third of the submucosal layer if possible, because too close to the mucosa, it makes bleeding, and too close to the muscularis layer, it makes perforation. So appropriate depth is also important point. And always keep in mind that you should avoid the blinded area to avoid the perforation during dissection. And the gravity is very important point. If you change the patient's position like this, you can expose the submucosal layer more easily. And in this video, the surgical field is not clear because of the water. So if you change the patient position like this, easily expose the submucosal layer like this and can keep the procedure. Regarding the complications, bleeding is one of the most important complication, and most bleeding can be controlled by the tip of the knife during procedure. However, if there is a intractable bleeding like this, we have to use hemostatic forceps or coagulosper to control the bleeding. From now on, I'd like to talk about the various methods of colonic ESD technique. This slide shows the meta-analysis data of a randomized controlled trial about the colon ESD technique. And in this presentation, they presented various kinds of techniques like a conventional ESD, traction method, pocket creation method, and hybrid ESD, and pocket and traction ESD. In terms of envelope resection, pocket ESD and pocket traction ESD and traction method is superior comparing to other procedure. And also for the R0 resection, pocket and traction method is superior. And conventional and hybrid ESD has a low side effect. Hybrid ESD is a combination of advantage of EMR and ESD, and it uses snare to remove the remaining region after some procedure, after some mucosal dissection. It is suitable for the ESD beginners, and we usually use this method when facing adverse events during ESD like massive bleeding or perforation. And it is useful for the rescue method for difficult cases like fibrotic region or difficult to reach location. And we can use this to overcome the time-consuming procedure. In terms of complete resection and safety reason, ESD is superior in complete resection. However, it accompanies some risk like bleeding and perforation. And the ESD, the difficulty of ESD is followed by the hybrid ESD and EMR and EPMR and cold snare polyneuropectomy. And the other another method is the traction method. I don't use frequently this method. However, in sometimes there is a delay in the procedure. We use sleep to lift the mucosa flap to the opposite side like this and complete the procedure. And there are several modified methods for the tunneling method. This is double tunnel method. And with in the cases of a large colorectal lateral spreading tumor, you can make a double tunnel like this and can facilitate the submucosal dissection. And also palisade method, the region occupies larger than the half of the circumference. There is some obstacle when you finishing the submucosal dissection in left side. And in this case, you make multiple tunnels. It's a palisade technique and can facilitate the procedure. But recently, this procedure is gaining popularity, and it's a cell line immersion and irrigation technique. We usually use the saline for the this kind of procedure, and not distilled water. Yeah. And after immersion with the saline of the lumen, and you can take a mucosal incision like this, and with continuous irrigation with a pump, water pump like this, and it makes a mucosa flap lifting under the water, so it makes rapid dissection in colony regions. So it's a very useful technique. And in this technique, there is some randomized studies comparing to the conventional ESD. In terms of emboli, R0, adverse events, there is no difference with underwater ESD. However, there is no standardized ESD setting. Usually, we use a same setting with conventional ESD. However, in some cases, we have to increase the electrosurgical unit setting. And also, it accompanies some risk of aspiration in esophageal and gastric ESD. And there is, as you saw in previous video, it makes air bubble underwater. So there is a case report that the explosion underwater and make some because muscularis damage during the procedure. This is a conventional ESU setting. We usually use Orbi Bio 300, and in many centers in Japan, not Korea, but they use Bio 3 ESU machine, and the setting is for your reference. The last topic is closure of the ESD. We usually use this conventional clip for the closure. And there are lots of methods shown in this picture. The first one is using detachable end loop, and also conventional clip, and underwater clip, and the O-ring suture. And in the low column, you can see OTSC for the closure, and overstitch, and also hand suturing from Olympus. Altogether, endoscopic closure is useful in many data that it can reduce delayed bleeding after gastric, duodenal, and colorectal ESD, as well as delayed population after duodenal ESD. However, we have to consider closure associated costs and the indication and limitation of close technique that should be further investigated. This is one of the example. I perform gastric ESD and it is complete. After ESD, I performed a closure with conventional clip like this. However, several days later, the patients presented with hematemesis, and we have to control bleeding with the exposed vessel. So it's useful in some instance, not perfect. Last, I'd like to show some novel concept of knife. It's named hybrid knife, H knife. It's a combination of I-tip and O-tip. It's a combination of insulated knife and needle knife. And as I mentioned, we need lots of instruments during the procedure. However, with this knife, you can the procedure in one step. So we compared this knife with the Olympus knife in gastric ESD, and we totally enrolled 100 patients and randomized to H knife or IT knife. And the patients has gastric ESD dysplasia or EGC. And the variables in this study was total procedure time, resection time, and the all time was measurement were recorded using an endoscopic timer. This is procedure, representative procedure with H knife. After defining the lesion, can make a mark with I knife like this. And it has a sharp knife. You can make a dot in the open state. However, in close, it's possible. So, And the mucosal injection, we can make mucosal incision with the eye knife like this, and switch to a knife without exchange to knife, and proceed the procedure without exchanges. So there is no difference from the patient characteristics in two groups, and total procedure time tends to be lower in H knife, and resection time was significantly lower in H knife. So there is no difference from complete resection and complication. So this novel H type can reduce procedure time in gastric ESD. And I think it can improve the convenience of the procedure for endoscopist. So, ladies and gentlemen, this is my last slide. In my presentation, I introduced various kinds of knife and instruments for the colonic ESD. And I also mentioned the various kinds of method, and including saline immersion techniques. This would be, I hope this would be helpful for your clinical practice. Спасибо.
Профессор. Does anybody has a question? Есть у кого-нибудь вопросы? Әріптестер, сұрақтар бар ма? Қысылмаңдар. Сұрақтар жоқ па? Нету вопросов, да, ни у кого?
No questions so far. We don't have.
Thank you much.
Okay, we will move on to the next lecture. The speaker is Professor Hiroshi Kashida. He is a world-renowned GI endoscopist, and personally, I think he is a very good teacher. His lecture has always abundant of lessons. So, and he has worked for Kinda University as a faculty of medicine, Osaka, Japan. But I found that he recently moved to Kawanishi City Medical Center. So his lecture today is basics and tips for colorectal ESD. So please.
Thank you for your kind introduction, and thank you, Kadat, for kind invitation to this important conference. Yeah, as you see in the slide, I visited this country 12 years ago. At that time, I attended the Congress, and I also performed live endoscopy. I was required to perform 8 cases in one day for live demonstration. And after this conference, after this conference, I have accepted several Kazakhstan doctors to my department for training, like these. And for the last endoscopy forum of Central Asia, I talked about the detection and diagnosis of early colorectal cancer, but just online, not face-to-face. So this time, I'm going to talk about basics and tips for colorectal ESD. And as Bjorn introduced me, I just moved to another hospital, Kawanishi City Medical Center, just last April. The previous speaker, Professor John, talked about colorectal ESD much. So my lecture may overlap in many parts, but I'll try to do my best. It's my honor to be JGS guideline, a member for JGS guidelines for colorectal ESD EMR. The slide shows the list of equipment I daily use for colorectal ESD. CO2 is important, and scopes should be equipped with irrigation pump. And food, I prefer tapered food, short ST food by Fujifilm. And solution is very important. I prefer hyaluronic acid for correcting ESD. And the knife is, of course, important. And the important point is it should be equipped with water jet. So water jet for the scope and also for the knife is better for corrector ESD. And the slide shows my settings for Vio 3 in corrector ESD. I use 5 pedals for corrector ESDs. 2 pedals for water jet, 1 for the knife, and 1 for the scope. And yellow pedal for the end cut mode, and blue pedal for the coagulation, forced coagulation or safe coagulation or whatever coagulation mode. And another pedal for the hemostatic forceps. So I use 5 pedals. I'm not an octopus, but I don't want to use my fingers and my hand for change the setting for the current. So I use my I usually use my left foot for controlling these 5 pedals. And during corrector ESD, most important is good visualization of some mucosal layer. And there are several techniques for realizing it. Utilization of the gravity, device-assisted traction, tunneling, bridge formation or pocket creation method, or undersailing method, as the previous speaker talked about. So first, I'll focus on device-assisted traction, but there are many kinds of devices for traction. So I just show you one case. This equipment was invented in Japan, and this has clip, spring, and loop part. And how to put the traction in the gastric? Maybe traction away from the scope is frequently used. So you have a retroflex view, and the traction is applied away from the scope. But in esophagus or a corrector ESD, traction should be toward traction toward the scope is better than the traction away from the scope. I'll show you one case. The lesion was located in the cecum, but luckily, appendix office was not involved. So I made the circumference incision, not total circumference, about 1/3 of the circumference was cut first. And so you can see some fibrosis here. So widened the mucosal incision and put the device so you can see the loop part of the device and put another click to move this device toward you, maybe 2 folds away from the lesion, and fix it on the lateral wall of the column like this. So now you can have the traction and you can have a better view of the submucosal layer like this, although there was a subfibrosis underneath the lesion. And the mucosal incision was extended to total circumference incision. And the mucosal incision is now finished. And after that, a submucosal dissection is rather easy thanks to the traction device. So in the cecum, the lesion is often associated with fibrosis, but in this case, traction device worked very well, and submucosal dissection was performed rather quickly. So traction device can be very useful tool for the corrector ESD. This is the final part of the dissection. The procedure was finished, and the appendiceal orifice was totally saved. So no injury to the appendiceal orifice. The lesion was
intermucosal cancer, or you can call it a high-grade dysphagia in adenoma. Now, I'd like to show you a tunneling method, or you can call it a bridge formation method. Tunneling method and pocket creation methods are similar, but a little bit different. But I prefer tunneling method. And during corrected ESD, when the flap becomes large and if it is bent too much, the knife tip might easily touch and injure the muscle layer, like in the slide. So merits of tunneling or pocket creation. One, you can have a good view of the lesion, muscle layer, and the submucosal layer. And you can advance parallel to the muscle layer like a poem procedure without injuring the muscle layer. So this is very important for the safety. And the liquid cushion is maintained longer, so you can save the solution and time for injection. And during the procedure, mucosal incision at the oral side can be made either at the beginning or toward the end of the procedure. So when the tunnel is completed, the lesion forms a bridge. It looks like a bridge. Lastly, a bridge abutments on the both sides are cut. I'll show you a case with a large lesion and the rectus sigmoid. So first mucosal incision at the endoside side was made and tunnel was made and tunnel was completed. And I cut the both sides of the bridge abutments on the left and the right. And the lesion was a slightly invasive cancer. And I'll show you double tunnel methods. And so about this also the previous speaker talked about. And double tunnel method is useful when fibrosis or invasion is suspected at the center of the lesion. This is a case in the rectus sigmoid. So two tunnels were created on the left side and the right side of the lesion. And after that, central part was dissected, and central part was associated with some fibrosis. And central part, after central part was cut, there was a bridge formation. One big tunnel was completed. And I cut the both sides of the abutments, left and right. So the video shows one tunnel was completed first on the left side, I think. And after that, yeah, first on the right side, and now on the left side, another tunnel was created. The tunnel on the left side. And finally, the central part was dissected. So because there are two tunnels, central part was elevated because of some gravity. So this is a kind of traction utilizing the gravity. Now, central part was a little bit hard to dissect. Now you can see the final part of the dissection of the central part. Yeah, you can see the usefulness of the tapered cap. So finally, the abutments of the right side and the left side will be cut. Left side. And ESD was completed.
So beautifully done, and it was just high-grade de novo. Another case for double tunnel method, the lesion was not so big, but the lesion was associated with fold convergence. So maybe there was some fibrosis or an invasion. So two tunnels were created first, and central part with fibrosis was cut. And you can see now you can have a big one tunnel completed, and the lesion is just in the air. And finally, the both sides were cut. So the lesion was rather big, and histologically it was invasive cancer. So even in such case, double tunnel method can be done, and it is very useful. Finally, I'd like to show you some under-saline ESD. You can call it underwater, but the saline is better than normal water. So under-saline ESD. And Elba company has now EIP2 irrigation pump, and it can be used with the generator. And EIP2 pump delivers a pulse pressurized jet of fluid automatically while the current is on. You use the current during the dissection, and the water comes out of the water irrigation pump automatically. And it facilitates a clear operative field. And I personally connect the pump not to the scope, but to the knife. Usually they connected the pump to the scope, but I prefer to connect it to the knife. I'll show you the video later. So the lesion was 30 millimeters, but it was in the cecum. The merits of undersaline method is one, the submucosal layer is maintained open, and two, the view looks magnified because of the water, and three, there's less need for changing to the injection needle. You can save time and money for the injection. And four, buoyancy helps the procedure. I'll show you the video from now. So you can see the water is coming out of the knife during the dissection. Can you see it? Water is coming out and always opens up the submucosal layer. So it can be very safe and easy to identify the submucosal layer. And because I am not very sure, because I connect the pump to the knife, not to the scope. So there's less bubble during the procedure. Professor John talked about the bubbles during the underwater method, but you can see there are very few bubbles during the procedure. So the water irrigation always opens up the submucosal layer. So now I was making the mucosal incision to make it a total circumference. And now you can see the buoyancy during the underwater method. So the lesion is floating in the water because of the water irrigation. So you can see in the submucosal layer very quickly, very easily. So this would be the final part. The dissection was completed. So cecum can be the difficult part for correct ESD, but it was done very safely. And it was SSL histologically. So I'd like to summarize my talk. During colorectal ESD, good visualization of submucosal layer is vital, very important. And there are several techniques for realizing it. And as I said, utilization of the gravity is the base. And device-assisted traction can be useful, and tunneling bridge formation method can be very useful. And undersailing method is rather new but very useful. And you can combine these techniques all together for difficult cases. Thank you for your attention.
Thank you so much.
So, are there any questions or comments? Okay, please.
Use microphone.
The traction device that you showed us in Secum, how do you make it or where do you buy? How is it possible? Traction with the clips.
I'm sorry. That device is sold only in Japan and in Korea, maybe. No. Maybe in Vietnam or something. But so, and it costs one clip costs 5,000 Japanese yen. That is 30 US dollars, 25 or 30 US dollars. Not very cheap, not very expensive.
Yeah.
But there are many kinds of traction devices. Maybe you know the some Boston Scientific sells some rings, rubber rings, a 3-ring device for 3,000 Japanese yen or something. So maybe that's enough. And if you don't have any such device, you can make it handmade. You can use some threads to make a big ring, but it doesn't have elasticity, so it's just thread. But it's better than nothing. So you can make it handmade if you want.
Dr. Hasan Yilmaz from Turkey. Thank you for your excellent talk. Sometimes we experience fatty infiltration at the submucosa, especially at the IBD patients. It's very common. So while we are dissecting at the submucosa with the fatty infiltration, when we use the coagulation method, it's melted the fat. So your scope view is easily disappear and blurred. So do you have any advice for this? Because maybe you are performing the EST at the SICUM and coming back, cleaning, going there, it's very time consuming. Is the underwater EMR, or sorry, EST can help us? Or do you have any advice for this proposal? Thank you.
Very good questions. And yeah, for the fatty patient, and yeah, there are several techniques. So at the beginning, you should clean the lens beforehand with the cleaner, the lens of the scope, and also the tapered cap or any cap you use, any food you use. You should put the cleaner beforehand to perform correct ESD, especially in the secant or ascending column. That's very important. And underwater or under saline ESD might be better to keep the cap or the lens cleaner than without it. So maybe I think it helps. And during the dissection, I often encounter fatty tissue in the submucosal layer, as I said. And the important thing is the fat has high impedance for the electric current. So hard to cut because of the high impedance. So you had better spare the fatty tissue. So, but fatty tissue usually they're at the middle of the submucosal layer. So very deep part or very superficial part are better for the dissection than cutting the fatty tissue itself. But I usually use the deeper part because there are less vessels at the deeper part. it can be a little bit dangerous, but less vessels. In the superficial part of the submucosa, there are many vessels, and among the fatty tissue, it's sometimes difficult to find the vessels. So you must be very careful. So I choose the deeper part of the submucosal layer for cutting, especially in fatty patients. And so in that case, the traction of a tunnel method or underwater method can be useful for fatty patients too, to have a better visualization of submucosal layer. Okay.
Professor Kashida, how about using the cutting current when you meet
Fatty
fat?
tissue,
Yeah, but
fatty tissue.
actually, in my to my experience, I usually use coagulation current when I dissect some mucosa layer. But as you mentioned, fat is very difficult to dissect. So in those cases, I change the mode to cutting current. And my experience, fatty area doesn't have usually much amount of vessels. So bleeding risk seemed to be lower. So I prefer using cutting current without much fear of bleeding.
On fatty tissue, there are many vessels. They are usually thin, not thick. So not many thick vessels exist, but there can be many thin vessels. So I prefer, yeah, you can choose cutting current for the dissection, but you must be careful about the bleeding in that case.
Okay, are there any questions? No? Okay, thank you.
Thank you very much.
The next speaker is Chon Sik Byun, professor from Seoul, Korea, professor Department of Gastroenterology and director of Digestive Endoscopy Center, Asan Medical Center, University of Ulsan College. And his topic is stenting of in obstructive colorectal cancer. Oh, sorry, endoscopic resection of large colorectal neoplasia. What is the best strategy? Please.
Thank you. Good afternoon, ladies and gentlemen. First of all, I'd like to express my special thanks to the organizing committee and Dr. Batirbekov Kanat for the invitation to this wonderful conference. My talk is not about the technique, but mainly about the reasonable strategy for endoscopy resection method of large colorectal neoplasia. So let me start with indications. Endoscopy resection methods for large colorectal lesions include ESD and piecemeal mucosal resection. So piecemeal resection is, as you know, technically very easy, and even very huge lesions can be resected safely by this method. But piecemeal resection has some weaknesses, such as high local recurrence rate, which was reported to be 20% in the large meta-analysis. Despite this high local recurrence rate, most benign local recurrences can be managed by repeat endoscopy resection. So this is a large prospective multicenter study, and this study showed that about 88 to 95% of benign local recurrences could be managed by repeat endoscopy resection. So if the recurrence is benign after piecemeal resection, like this picture shows here, then the local recurrence is not a serious problem because we can manage this benign local recurrences by repeat endoscopy resection. But If the local recurrence is a cancer, like this picture shows here, then adequate treatment would be very difficult. So piecemeal resection is good for benign lesions, but not for malignant-looking lesions. Another weakness of piecemeal resection is difficulty in accurate histological evaluation of cancer depth, lymphovascular invasion, and resection margin status, and so on, which makes the decision of necessity of additional surgery very difficult in case of early colorectal cancer. How about ESD? ESD has can achieve very high angular resection rate, which was reported to be about 91%, and the local recurrence rate is very low, which was about 2% and or a little lower in a meta-analysis. Another strength of because of high possibility of angular resection, detailed histological evaluation is also possible. So we can decide the necessity of additional surgery very accurately and easily after ESD with angular specimen. However, ESD also has some weaknesses, such as high complication rate, especially high perforation rate, which was about 5%, and long procedure time, which was reported to be about 1 to 2 hours. So, if you are a specialist for colorectal ESD, your indications for ESD may include both large benign polyps and early colon cancers to minimize the risk of local recurrence, because your ESD perforation rate may not be very high and your ESD procedure time may not be too long, but acceptably long. But in general, the best indication for colorectal ESD, I think it may be large tumors for which angular resection is required for minimization of the risk of local cancer recurrence and for accurate evaluation of histological features of cancer to decide the necessity of additional surgery accurately, even accepting long procedure time and a high perforation rate. And that would be suspected superficial submucosal cancer. In contrast, piecemeal resection may be enough for definitely benign looking lesions, such as granular homogeneous LST, as this picture shows here. Another possible option is planned piecemeal resection for a large benign polyp with definitely focal cancer area. So if some mucosal cancer is suspected only in a limited area, like this large nodule here in this picture, this area suggestive of submucosal cancer can be resected as a single large piece. And then all the other benign-looking area can be resected by piecemeal fashion. On the contrary, if submucosal cancer is suspected multifocally and or broadly, then angular resection by ESD should be tried. Okay, let me move on to several technical tips to improve piecemeal mucosal resection outcomes. Although the procedure time is shorter than ESD, the procedure time of piecemeal resection of a large polyp is still longer than that of conventional EMR of a small polyp. So CO2 insufflation is better in terms of lower instance of post-procedural pain and bloating because CO2 is absorbed rapidly to the bloodstream compared to the room air. the principle of gravity is the same in case of a piecemeal resection as ESD. So, sorry. If a lesion is located at the dependent position, then residual feces here may make the operation field poor and invisible, and can also result in a severe peritonitis if perforation occurs during resection procedure. Therefore, the patient position should be adjusted so that the tumor is located at the non-dependent position, and the resected specimen and residual feces should be located at the opposite dependent position. By doing this, we can ensure a clear operation field, and we can also ensure lower risk of severe peritonitis even if perforation occurs during the resection procedure. Sufficient tumor-free normal resection margin should be ensured, and effective snaring is commonly difficult in flat lesions. So in this case, pre-cutting by using the snare tip can be made first, and then effective snaring can be performed without the risk of the possibility of snare slipping. The snare size can be selected according to the target resection area. So a small snare may be better for resection of a small target area, and a large snare may be better for resection of a large area. All small visible residual lesions like this and this should be completely resected by using a small snare like this picture shows here. But snaring of this very tiny residual lesion is very difficult. So in this case, heart biopsy of this very tiny lesion using cutting current may be very effective, may be very useful for a complete removal of this tiny residual lesion, which is called hot aversion technique. Could you run the movie clip? Click the. So after removal of all visible residual lesions, additional ablation technique such as snare tip soft coagulation is very effective to minimize the risk of local recurrences. So this is a prospective randomized control trial in Australia. And in this trial, snare tip soft coagulation decreased the risk of endoscopic recurrence and histological recurrence significantly compared to the control group. Please run the movie clip. Algoplasma coagulation, APC, could also decrease the risk of local recurrences. So this is a prospective case series, and in this series, the local recurrence rate was only 2% after a piecemeal resection followed by APC. Now, let me move on to several technical tips of ESD, but this part is almost overlaps with the previous speaker's lectures, so I will very briefly touch. As two previous speakers mentioned, the various traction method is very effective, and pocket creation method is also very useful. And the advantage of a pocket creation method includes these issues. So pocket creation method can prevent the leakage of injected solutions because there is a no incision at this point, and pocket creation method can also ensure good traction by stretching the submucosal tissue directly by the inserted endoscope itself. And this method can adjust the approach of angle to the proper muscle layer more easily. And this method also can minimize the adverse influence of respiratory movement because the colonic wall and the inserted endoscope move together simultaneously. So the operation field is very stable. Please run the movie clip. Water pressure ESD is also mentioned by previous two speakers. And as you can see here, in this method, active water pressure to the submucosal layer is effective for efficient visualization of even a difficult area such as a fibrotic submucosal layer. So this is a comparative study, and in this study, adverse event and angular resection, complete resection, and curative resection rates were not different between water pressure ESD and conventional ESD. But the median procedure time was significantly shorter in the water pressure ESD, which suggests the technical simplicity of this technique. Robotic platforms, robotic instruments can be also another option to enhance colorectal ESD. So this is a movie clip showing a human rectal ESD trial with resection defect closure by using this innovative robotic traction device. Okay, based on my talk today, let's see several cases. This is the first case, granular homogeneous LST, and all the tumor surfaces here and here and here showed JNET type 2A and type 3L or type 4P patterns. So I thought that the pathology would be benign adenoma. Therefore, I performed piecemeal mucosal resection for easier procedure and more safer procedure. And the final pathology was benign adenoma with focal high-grade dysplasia only. This is the second case, non-granular flat elevated LST, and the tumor surfaces showed mainly JNET type 2B MBI pattern and type 5IP pattern, suggesting superficial submucosal cancer. So I performed ESD for angular resection, and a specimen was resected as angular fashion, and the final pathology was superficial submucosal cancer as anticipated. This is the last case, granular nodular mixed LST in the rectum, and this large nodule area here showed JNET, mainly JNET type 2B, and some areas JNET type 3, and mainly type 5 IP patterns suggesting submucosal cancer. But all the other granular area here and here showed JNET type 2A and type 3 LP patterns. So these granular areas, fine granular, homogeneous granular areas must be a benign adenoma. Anyway, because submucosal cancer was suspected in this tumor, ESD may be a good treatment option for angular resection in this case. But I think there can be another option. So in this case, because the suspected submucosal cancer was focally and clearly demarcated only at the large nodule area here, I performed several times of piecemeal resection for benign-looking areas here and here first, and then finally I resected the large nodule area, suggesting a submucosal cancer as a single large piece. And then I sent the resected tumor to the pathology department as two specimens. And the small granule areas here showed benign adenoma, only benign adenoma, and the large nodule area here was superficial submucosal cancer. And deep resection margin of this large nodule was clear, and the lateral resection margin showed involvement only by benign adenoma. There was no cancer involvement at the lateral resection margin. So I think a planned piecemeal resection in this case might be curative in terms of cancer treatment. This is the table summarizing my talk today, and there can be another possible indication of colorectal ESD, but which is UC-associated dysplasia. But because of time limitation, I will skip this slide. And so, in summary, piecemeal resection can be a good treatment option for definitely benign-looking colorectal neoplasia. Visible small residual lesions should be resected by small snares and or hot aversion technique, and additional ablation techniques such as snare tip soft coagulation or APC can be added to minimize the risk of local recurrence. And ESD may be the best option for submucosal cancer, suspected early colorectal cancer, and I hope innovative robotic platforms may play some role in the near future. And planned piecemeal resection may be considered in selected cases. So thank you so much for your kind attention.
Doesn't work. Not working.
So thank you, Professor Byung, for your nice talk. You talked about piecemeal EMR, and in piecemeal EMR, which part do you start resection?
I think there is no how can I say, there is no universal rule. And in my case, I usually start at the easiest portion. And in my case, it is usually the anal side. So I perform from the anal side.
Okay, yeah. The most important thing is to remove the most important part, unblock, not piecemeal.
Yes, right.
That's the basics for piecemeal EMR. So maybe you can start from the anal side, from the largest nodule first and the small nodules later, but in the last case, in your last case, you resected the peripheral benign part first, and at the end, removed the most important part, unblock. Yeah, that is another strategy. So anyway, the most important thing is, I think, is to remove the most important part, unblock.
Yes, yeah, right.
So before and after that, anyway, you can do it.
Yes. So if we start from the benign-looking area, we should be very careful not to touch the most important, most advanced-looking area.
Yeah, thank you. Thank you very much.
Thank you for a great presentation. I would like to ask, would you recommend to always perform tip snare or archon plasma coagulation after piecemeal EMR? Or when do you recommend to perform this coagulation?
Personally, I always perform additional ablation technique, and between the snare tip soft coagulation and APC, I prefer APC actually. Although the scientific evidence is suggests snare tip soft coagulation more frequently because, as you know, there are many randomized control, not many, but several randomized control trial which compared, which showed that the usefulness of snare tip soft coagulation with high quality evidence, and there is very few papers with low level evidences that shows the usefulness of APC. But personally, when I performed snare tip soft coagulation, snare tip soft coagulation is basically a contact method. So we should contact the snare tip to the resection margin area. To me, it was not very easy. Uh, uh, and another point is because it is contact method, it cannot cover it can cover only the resection margin, resection edge. It cannot cover all the resection also base. But on the contrary, APC, it is non-contact method. So APC can jet the argon plasma when we place the APC tip just roughly around target area, then it can cover a broad area. So it is technically easy, and it can also cover whole the resection also base. So to me, it was technically easy, and logically it seems more helpful to cover all the surfaces. So I use APC in after piecemeal, all piecemeal cases.
오케이, 감사합니다.
Yes.
And next speaker is Dr. Vladimir Malkov. His topic is endoscopy treatment of laterally spreading intestinal tumors. He is a head of endoscopy department of St. Petersburg State University, after named Pirogov, and Clinic of High Medical Technology, St. Petersburg, Russia. Please.
Добрый вечер, дорогие коллеги. Большое спасибо за то, что все...
Good evening, dear colleagues. Thank you for staying here. We have here very interesting interaction. I would try to give some surprise. The topic of my speech is continuation of endoscopic dissection. I would like to dwell on the right part of the large intestine, because while going on, we will see quite a number of exciting moments. I would not dwell on statistical data, but topicality of this problem is sufficiently high because colorectal cancer is the second one in regard to mortality. And during a life, it amounts to 4% of probability. So, speaking of cancer and the ways of cancerogenesis, 1928 is a significant date. At that time, pathomorphologists for the first time came to the conclusion that polyp is equal to cancer because any cancerous process starts with polypogenesis. And this theory has changed. Now it is called like the link between adenoma and cancer. Adenoma, carcinoma are about 70% of all cases of cancer, and there are inflammation process and development of cancer de novo. And when we read just papers, they say that in 30% they do not view cancer. Pathomorphologists say that 70% of cancer are the remnants of adenoma. And today this approach has been confirmed, and adenoma is pre-cancer factor and it requires resection. So adenoma should be resected because it lowers mortality from cancer. Why do I talk about the right part of the large intestine? If we are speaking of anatomic specificity, the right part is the function of the liquids of electrolytes, and the width of the wall of the thick intestine amounts to 1.5 millimeters. But when we go to the next, the function of the intestine changes, and the movement of thick remnants are going, and in the larger intestine, it achieves 2 or 4 millimeters, and the right part is regarded as the most sensitive part, and the peculiar features of blood supply, the different arteries, the right colic artery and collateral blood supply makes it more sensitive, and risks of perforation become more frequent. Even in ideal dissection of the right part of this intestinal, the perforation amounts to 5%. This also testifies to the responsibility, complexity of visualization. These are different gaustras, and the angle of approach, that is the prolonged of the walls, and complexity of fixation of endoscope. The right part of the intestine is less fixed. Risk of perforation morphology also impacts availability of fibrosis, of necrosis, coagulation necrosis, and the need of urgent interventions. And each penetration through the large intestine may result in undesirable lesions and complications. And our experience, 101 dissection in the right butt, the age from 50 to 70 years, and from group from 50 to 70, 63 was the average, and the size of the tumor was not more than 30 millimeters, 80% up to 40 millimeters, and more than 40 millimeters, 27 patients. According to Paris classification, the greatest number is in the right part with the protective component, and then 2 plus 1S. And all instruments, we analyzed our work, and in this work, we obtained the next complications: light, heavy, and technical complications. Intraoperational perforation 10, of them intraoperational bleedings, those which we managed to settle during operations. Perforation took place, but the patient was recovered. Intraoperation delay of perforation, but accidental things can be very difficult. Perforation with 5 patients, and were cases when we did not manage to carry out the section, and fibrosis took place with analysis and reasons. In several cases, we had to pass over to piecemeal resection and expanded biopsy, and technical complexities. 3 patients and 1 patient was forwarded to surgical treatment, and 1 to deep invasion. Types of complications depending on histology: intraoperational perforation 25%, delayed perforation about 37%, and benign tumors more frequently are accompanied with bleeding. Linked to the age, the older the patient is, more frequently we have different complications during endoscopic dissection. The size of the tumor, depending on the tumor, the number of complications is increasing. The link with the length of operation. After analysis, we realized that the length of the operation also impacts on the number of complications. With the length of 120 minutes, complications grew to 18%. Histological data: all patients from this group had the diagnosis of benign tumors, but after operations, 14 patients were referred to the group of malignant tumors, and complications due to transition to another histological group, and heavy complications with malignant lesions. Thank you very much. Actually, in work with the patients of the right part of the large intestinal, we usually have not only endoscopists but also surgeons behind. Either you have special just mastery of this or that method, because urgent perforation may require extra urgent operation, and it happened at the moment of some signs of possible peritonitis, and the terms of hospitalization were not violated, but some urgent surgery methods were employed. So some things we did not manage to analyze. Later, I would do it. A very detailed selection of patients and building the ways of treatment together with the patient. Patient should be aware of all the phases of treatment. That is the way of minimal invasive treatment. And also speaking of different invasive just opportunities. This group also gets into group of complicated the postponed operations. Thank you. If any questions, I am prepared to answer. Thank you very much. Excuse me for asking questions permanently. Just maybe in the framework of discussion first. Generally, how rational it is to do dissection in the right part. We know large intestine is heavy, but the right parts, risks and complexity of surgery is less. Secondly, in the last slide, you showed the rationale of selection of patient. 87% of them, of those dissections, they were benign. And the third question, what is the rationale of when is it necessary to get to dissection of the submucosal layer? The right part of dissection, it should be done endoscopically. And today you have seen quite a number of excellent operations in different countries of our colleagues. And this already testifies to the fact that it is reasonable. Why? The goal of this work was not the link between surgery and endoscopy, but naturally I tried to compare them. The right part of the large intestine, anatomical peculiar and blood supply actually parascopically can be done. If we get to the literature, surgeons have no less problems than endoscopists because this is the Mr. Moss Mr. Moses non-relevance and endoscopic resections are required, and the goal of our work and analysis of patients to check the factors which can impact the conduction of endoscopic dissection. And further on, we do not operate, we pass patients to surgeons. Unfortunately, I had little time, that's why I made this quick coverage. But usually there are vessels, just deviations, and some other problems which can surely just bring patients to postpone perforations. The older patients are, the higher is the risk of postponed perforation and complications. Heavy complications requiring urgent intervention were zero actually, but intraoperational can be linked with the curve of training. But complications which appeared as light anatomic syndrome um, and maybe sometimes the syndrome which could be easily settled with analgetics, but analyzing autotaxonon process, the question whether we need to pay attention to the right section of the large intestine, the answer would be yes, we do. But the majority of them did not require intervention of colostoma. They all ended with the timing which has been planned. So smoothly, we're moving towards low invasive treatment and correction of complications also testifies to positive conclusions. But I meant where you have benign formations, just for discussion. You showed only 5%, but when you spoke of the right but the result is very good, and your cases proved you actually get there with dissection, after dissection. Yes, there was some statistic in literature that I encountered. There they had recommendations no less than 50 dissections, but this requires certain skills of using endoscopic methods. My question is technical. Have you done in your study with subwater dissections? No, I am the opponent. I may explain why. I do not like how electricity works out. Though there is no sparkling, but how big volume of liquid can act in such cases. And there is a chance of quick aspiration and quite a number of debatable aspects. Thank you very much for your report. And some small remark whether we need to do this section in the right part. Certainly we need, but polyps can be easily settled due to the pocket method. Did you have patients where formation in appendix part we did not select them into a separate group, but here it's quite easy depending on the leisure. If we manage to outline it in such a way that when the formation could partially enter, we try to dissect the appendix and then go by circular way to dissection of the required part of intestine. 20 minutes of operation can settle all issues. That was in a dissection or it was fragmentary dissection. Now it was dissection. We have very strict oncological school. We stick to the golden standard. Thank you very much.
Beyond, and the second topic, stenting in obstructive colorectal cancer, focused on updated indications. Please.
Thank you, Chairman. It doesn't work.
Ребята,
I can.
подойдите, не работает. Указатель не работает, переключение, контроллер проверьте.
Oh, okay. Let me start with stenting as a bridge to surgery. So a 65-year-old lady visited my center because of defecation difficulty for 2 weeks. Her sigmoidoscopy showed obstructive upper rectal cancer, and the CT scan also showed obstructive mass and a dilated proximal colon. And there was no metastasis. Stenting was performed, and the simple X-ray on the post-stent day 1 showed still multiple air fluid levels, but the X-ray on the post-stent day 3 showed disappearance of air fluid levels and more dilated stent here. Surgical resection was performed after clean bowel preparation on the post-stent day 12. So this is a bridge to surgery stenting case, and this stenting as a bridge to surgery has been performed quite commonly in the past because the short-term post-surgical outcomes were better after stenting as a bridge to surgery compared to emergency surgery without prior stenting. This is a meta-analysis of 8 randomized controlled trials, and in this meta-analysis, the overall morbidity, such as intra-abdominal abscess or leakage and so on, were significantly lower after stenting as a bridge to surgery compared to emergency surgery without stenting. Because ischemia can be improved, ischemia at the dilated proximal colon can be improved by stenting. Primary anastomosis rate was significantly higher after stenting as a bridge to surgery. Despite these better short-term post-surgical outcomes, ESGE guidelines said stenting as a bridge to surgery cannot be the first standard treatment, but it should be discussed within a shared discussion decision-making process as an alternative to emergency surgical resection. Why is this? It is possibly because of a potential worse long-term oncological outcomes after stenting as a bridge to surgery. So this is a small-sized RCT for 3 years, and in this RCT, the overall recurrence rate was slightly, but significantly higher after stenting as a bridge to surgery compared to the emergency surgery without a prior stenting group. This is another retrospective study, and in this study, stenting as a bridge to surgery group also showed lower 5-year overall survival and higher 5-year cancer-specific mortality. A meta-analysis of these individual studies also showed higher systemic recurrence and higher overall recurrence rates in the stenting as a bridge to surgery group. Then why potential worse oncological outcomes after stenting as a bridge to surgery? One feasible reason is perforation, which can result in increased cancer recurrence. So in this stent-in-2 trial, the disease-free survival was significantly lower in the stenting as a bridge to surgery group, especially when there was perforation. So if a less experienced endoscopist performs bridge to surgery stenting, and if the procedure is technically incomplete or complicated by perforation, it may increase the risk of cancer recurrence later on. Then all study results are the same. Actually, it is not. This is a retrospective study, and in this study, stenting as a bridge to surgery group showed similar local and distant recurrence rates compared to the emergency surgery without prior stenting group. This is data of my center, as a medical center, and we performed a retrospective propensity score matching analysis for more balanced investigation. And in our data, both overall survival and recurrence-free survival showed no difference between stenting as a bridge to surgery group and emergency surgery groups. This is a European multi-center RCT, and in this RCT also, both overall survival and disease-free survival showed no difference between both groups. This is a very recent study this year, and in this study also survival probability showed no difference between both groups. Not only these individual studies, but also some meta-analysis of many studies, like this meta-analysis of 24 studies, also showed similar 5-year overall survival and similar 5-year disease-free survivors. Then why are there different outcomes between different studies? I think it may be possibly because of heterogeneity in study designs, such as RCT versus non-RCT, and heterogeneity of endoscopists' expertise level between studies, and heterogeneity in definition of obstruction, and so on. So as you can see in this table, some studies enrolled endoscopists with high technical success rate, while other studies enrolled those with low technical success rate. This may have may have contributed to the differences in perforation rates between studies, which may have resulted in difference in outcomes. So based on these debatable long-term oncological outcomes, ESGE guidelines said sufficient discussion is necessary before the decision of stenting as a bridge to surgery. And the discussion should include availability of required stenting expertise in individual centers and risk of stent-related perforation and potentially higher recurrence rates and similar overall survival and lower overall complication rates and so on. The 2022 guideline by American Society of Colorectal Surgeons also suggested a similar recommendation, that is the choice of stenting as a bridge to surgery versus initial surgical colectomy should be individualized based on patient factors and local expertise of the institution. So if stenting as a bridge to surgery is performed with high quality by an experienced endoscopist, post-procedural morbidity, such as perforation, may be rare, which can result in lower post-surgical morbidity, such as intra-abdominal abscess. Then we can start chemotherapy earlier, which can result in better survival. So, for example, if a patient is young without comorbidity, and if the patient is healthy, and if your center has excellent emergency surgery team, then emergency surgery can be the first a good treatment option to avoid potential worse oncological outcomes. But in contrast, if a patient is old with comorbidities, and if your center has expert endoscopists, then bridge to surgery stenting may be a very good alternative to minimize emergency surgery related morbidities and mortalities. Now, let me move on to the palliative stenting briefly. A 75-year-old man visited my center because of defecation difficulty, and his sigmoidoscopy showed obstructive colon cancer, and CT scan showed multiple hepatic metastasis, which means cure intent surgery is impossible. So stenting was performed and the patient underwent chemotherapy. So this is a palliative stenting case. And like this case, ESGE guideline suggested colonic stenting as the preferred treatment option for palliation of malignant colonic obstruction. Let's see why. So this is meta-analysis of 9 studies. And in this meta-analysis, palliative stenting showed slightly increased risk of long-term post-surgical, post-procedural complications compared to the palliative surgery group. And the long-term complications included stent migration, stent perforation, cancer reobstruction, and so on. On the contrary, the short-term post-procedural complication was similar between palliative stenting and palliative surgery groups. Short-term post-procedural complications included both stent-related complications such as early stent migration, early stent perforation, and surgical complications such as infection, leakage, etc. Interestingly, hospital stay was shorter in the palliative stenting group compared to the palliative surgery group. This is another meta-analysis of 4 other RCTs, and in this meta-analysis also, the hospital stay was shorter in the palliative stenting group compared to palliative surgery group. And this meta-analysis showed similar overall survival between palliative stenting and palliative surgery groups. This is another systematic review, and this systematic review showed lower 30-day mortality, shorter hospital stay, and shorter time to chemotherapy initiation. So based on these evidences, ESGE 2020 guideline suggested colonic stenting as the preferred treatment option for palliation of malignant colonic obstruction because of better short-term outcomes such as shorter hospital stay, lower short-term mortality, shorter time to chemotherapy initiation in the palliative stenting group, and similar overall survival between palliative stenting and palliative surgery groups. Although long-term complications such as cancer reobstruction, stent migration, stent-related perforation, those complications are slightly more common after stenting as a bridge to in the palliative stenting group. Rescue surgery is still possible in most of those cases. Okay, finally, let me briefly talk about several tips for colon stent insertion. The first issue is the time interval between bridge to surgery stenting and surgery. So if the time interval interval is too short, postoperative complications may develop quite frequently because of insufficient decompression. In contrast, if the time interval is too long, there is a risk of cancer progression because of delayed surgery. So the guideline suggests a time interval of approximately 2 weeks. This is a very recent study from Korea this year, and this study also showed that the lowest stoma formation rate when the time interval between bridge to surgery stenting and surgery is around 2 to 3 weeks. Next issue is stenting in case of acute angulation. So if the obstructing cancer is located at an acutely angulated area, such as the sigmoid colon, like this figure here, the guide wire insertion becomes easier when the tip of the scope is as closer to the tumor edge as possible. If the guide wire insertion remains still difficult despite close positioning, a papillotome can be used instead of a conventional catheter, as its adjustable bendable tip allows better alignment with the acute angulation of the stricture. The third issue is the stent length. As you know, self-expandable metallic stent shortens slightly upon its deployment. So it is recommended to use a slightly longer stent to ensure both the proximal and distal flares are properly positioned. For example, if you want 2 centimeter long flares at both the proximal and distal edge of cancer, then a 6 centimeter longer, 5 or 6 centimeter longer stent may be better than exactly 4 centimeter longer stent. The final issue is reobstruction after palliative stenting. So a 46-year-old lady presented with transverse colonic reobstruction by metastatic gastric cancer after palliative stenting. This is a previously inserted stent, and this area is reobstructed segment by tumor overgrowth. And I performed restenting, like this picture shows here. And the post-stenting CT scan showed reopening of the reobstructed segment by a newly inserted stent. So this is a small study about restenting outcomes, which showed 100% of technical and clinical success rates. And this study showed that the post-procedural stay was shorter in the restenting group compared to the surgery group. And the stoma creation rate was also lower in the restenting group compared to the surgery group. Okay, this is my final summary slide. I talked about 2 indications of colonic stent, and the first is stenting as a bridge to surgery, especially for older patients with comorbidities when expert endoscopists are available. And the second indication is palliative stenting, and I have talked about several tips for stent insertion. Thank you so much for your kind attention.
Certainly, Professor. And does anybody has a question? Сұрақтар бар ма? Әріптестер.
Are there any questions?
Окей. Жігіттер, коллеги, дайте микрофон. No.
Please give our people a microphone.
The question is, when you said restanding, it's as I understand, stand into the stand. Am I right?
Yeah, yes, right.
Okay.
So, you should you should watch the fluoroscopy simultaneously when you perform restenting, so that the distal part of the previously inserted stent and the proximal part of the newly inserted stent should overlap. Yeah.
Over the previous stand, yeah?
Yeah, the previously inserted stent and newly inserted stent should be overlapped.
Okay,
yeah.
Good. Thank you very much.
Thank you. Спасибо. И следующий у нас спикер из Республики
Next speaker from Belarus, candidate of medical sciences. Minsk. Modern possibilities of the AOHOA video system in the diagnosis of GI tract diseases.
Good afternoon, dear colleagues. Taking the chance, I would like to thank you for this opportunity. I'd like to dwell on the use of surgical laser with pathology of large intestine. And our department has over 20 years, and in our equipment, we use the solid laser system, but there were two minuses. First, very big size, and it was heavy to move it from one room to another. And secondly, there was some difficulty in pushing the pedal, and while the laser went through to the tissue, several seconds passed, and that was a problem. Later, we required a two-wave laser surgical system for endoscopy, and it has better impact on the surgical cover. But many patients are afraid and colleagues are afraid of the use of laser, but actually it is no worse than any other instrument. And in case of professional approach to it, it has very good potential. There are some nuances. The first one is you cannot use just the instrumental channel. There should be some cover. We use either some special needles or injections. And the second, the radiant has different diameters. For endoscopy, it should be 400 and 600. If direct view with strictures, 600 is sufficient. If we need it to work at more complex anatomic places, then it is recommended to use 400. Then endoscope would be more flexible. And for protection, we need to use 3 or 5 millimeters of protective cover so that there would be sufficient distance, and the endoscope should be also protected. The laser that I want to introduce had two waves of the impulse radiant, which is more sensitive in endoscopy, and beam should be used indirectly to avoid perforation. And depending on the length of wave, we need to select the length of the wave and the capacity. What indications we had stricture of the right large intestine, and it's more frequently anastomosis, and the restructure of the, and there are some fragments of post-operational observation. We also use for destruction of anaplasia of patients after reconstructive operation with formation of ileal reservoir. Well, it is very difficult to lay the curve, but with laser, it's quite easy to get rid of anaplasias. And also before that, we always check up patients on apparatus of high resolution. Also, laser destruction of vessel tumors can be used, and destruction of with the irrelevance of anastomosis. For resurrection of anastomosis, we can use when restructure is up to 10 centimeters. Usually these are patients who had the beam treatment. If it is bigger, then the laser destruction of the structure can be done through several just approaches, but with the first hospitalization, we try to get cases when endoscope can easily go. If endoscope goes smoothly, then we do not need repeated cases. If patients without storms, then we observe patients, and in case of need, we carry out secondary restomization. Why do we like laser? Because it allows to get rid of scopes and ligatures. If we do not derive them, they can become causes of recurrency if it is difficult to get rid of them with graspers, then laser can easily break them and then remove. So with the help of laser, everything is easy removed. That's the case of patient when we entered the direct intestine, but we saw the corruptive tissue, and we did not know where this action should be carried out. And from the part of the large intestine, but we tried to do laser transvestosomoma, rectoanastomosis, and all rechannelings closed the cyst. Then we carried out rechanneling only with complex stenosis because they have not smooth entry, and we send patients only in cases when stenosis with apparatus has been done. With first hospitalization, patients manifest improvement, and the next visit after a month, and sometimes we have one or two instances, and then in case of a need. The next, laser hemostasis. When we compared three types of hemostasis, and with laser hemostasis compared with the two listed, we have laser beaming ensures physiological mode of regeneration of tissues. And besides, the full-scale granulation of the connective tissue is ensured. After polypectomy, we took these remnants, and hemostasis was achieved, and the patient was released from the hospital. And the next, during enteroscopy, you see the outcome when we coagulated the hemangiomas, and we had only some whitened scars, and the level of hemoglobin was normalized, and we actually got a normal case. And the rectal anastomosis irrelevance. That's a complex case when through anal channels we entered a number of ligatures, and with the help of graspers we managed to process granulation, and the next day the patient felt better, the temperature fell down, and then surgeons added the appropriate therapy, vacuum therapy, but after we worked with laser, the passage was narrowed and vacuum therapy was more effective. In conclusion, I want to say that high energy laser is not a panacea, but it can be used with in the company with certain corrections. And in our country, the one-time tools can be applied only very strictly. So that's why our endoscopes, when we try to use laser for rechanneling, we are not using balloons in repeated times. Thank you very much. There is a question. Thank you very much for your presentation. It's very informative. Did you have chances of using laser with hemorrhagic diseases and in combining with other technologies? When we started to work with post-beaming structures, so laser we found as the most preferable. As to hemorrhoidal nodes, usually proctologists work with them, but they also use laser hemorrhoid lacto. I have a question. Is it possible to use laser in post-beam proctitis or for termination of hemorrhage? Is it with angiodysplasia? Yes, but my topic is lower part, but we use laser in stomach and in vessels and even in thin intestine, but in stomach, in two locations. We also use for watermelon stomach. Thank you very much. The next speaker, diagnostic. Коржева Елена Юрьевна, Moscow, Russia.
Hello, dear colleagues. We have some time left. Thank you very much all for all the organizers to inviting me. Before I start to talk about the modern I believe that many of you are endoscopists. In 1950, you perhaps know Uichi, Tokyo University, for the first time examined the inner part, the inner lining of the stomach.
Уиджи сказал, что можно осматривать желудок изнутри.
Both inside, everything as of today goes from Japanese schools. I would not be afraid to talk about this because whatever new is happening, whatever is opened, and those classifications and guidelines, they all start from Japanese school. And all equipment which today widely enters our market, I mean not only Russian market, but generally it all is linked to what the produce of endoscopic equipment based on visualization and those opportunities that expert endoscopic columns are provided by Japanese origin.
We also have Chinese producers, Ahua. It took the legal rights, what is now considered demanded and needed for expert endoscopy. When we talk about lower parts of the GI tract, I will not be talking about the technical part of the devices that we use. I will talk about the exploitation, the use part. there is a video system from Olympus and Fujifilm. Aqua provides state-of-the-art technology that is optic chronoscopy. The video system is very much demanded. So what are the technical characteristics of the Aqua company? I would like to say that for colonoscopies, everything that has to do with the upper part can be seen on the lower part. So the processor that is used when everything is applied on the processor, so you can save and transfer the data from the processor from one doctor to another. So what is required from us, from endoscopists? All the speakers said that before removing something, we've been talking a lot about resection, removal. We live in the era of screening. We need not only to see and understand and prove and make a decision for the treatment of the disease. Everything that we covered today is operative endoscopy. It all starts with diagnosis. So what is dependent on the endoscopists when coloproctologists, surgeons perform the endoscopy? That is, the optic chronoscopy comes into play. Everything that was said in the previous slides, all the classifications that our doctors said and showed, they covered all those characteristics that allowed to conduct a certain operation. So the company Ahua that strives to bring novelty in the equipment are optic chronoscopy opportunities in order to cover as much as ground as possible, to provide as much information as possible in order to fully describe a lesion. So if we take Fujifilm videoscopic system, optic chromoscopy, LCI, BLI, optical magnification, Ahua provides the same opportunities of optic endoscopy. That is the reflection of the white light, contrasting and improvement of the vascular picture, vascular structure. In order to give each other information, we should understand that we live in the same legal jurisdiction. Our report have to be in line with world guidelines. So in Ahua, so this regular mode, when we need to write a guideline, we will have to rely on NICE or Gillette. In order to in order to live up to the world standards, to certain standards, we will need to have certain organizations that we can obtain those standards from. Now, if we talk about CBI Indigo, that is the agent that improves the contrasts of the vessels. So why am I saying this? Whatever company goes on the market, it for the white light. So the pictures that you see, thanks to xenon lights, you can see them as any endoscopy wants to see. The higher the qualification the endoscopist, the smaller the neoplasm he will be able to identify. He will be able to see that on a monitor. So video endoscopic equipment comes into play. What Ahua company strives to? First is simplicity. Second is flexibility. Make those bolts, the equipment parts flexible, easy to use. So for the company to live up to higher standards, they have to be comparable to those best equipment providers. So this colonoscope, FFHD CL200JL, is convenient, is very comfortable to use to do colonoscopy for a long time. By demonstrating its own experience, therefore, within the 1.5 months that we had this equipment, this Moscow multi-specialty center, in its endoscopic department, it has outpatients and inpatients. In 1.5 months, 240 planned procedures were provided using this equipment. 240 colonoscopies. This is a fact. These are the real numbers that we show, that we have. 72 diagnostic procedures, that is only 30%, and the rest are operative. They were for mucosal ectomy or dissection, depending on the formation. So there are several clinical cases. Endoscopists in the room will understand what I'm trying to convey here. NBI, LCI. So to show that this is the one information, not epithelial 01S, GNet2, SANA2, UD3L. I'm saying this just because the system that I'm talking about is what we are striving to in order to talk about the adequacy of our conclusions. So the second epithelial neoplasm, in the white light, you can see the O2 regular in the regular NBI and aqua indigo, depending on what filter we have, is the reflection of what we get from Fujifilm. So we can say this is 0.1 0.1 epithelial neoplasm, SANA2, CUDA4, NICE2, GNet2A, and another clinical case, optical chromoscopy using this equipment, white light, regular aqua indigo. So we make a conclusion. O1S, NICE3, JNet 2B, SANO2, CUDO5, depending on what picture of the vessels and the mucosum. So here we can see cancer. I believe everybody can see that. So optic chronoscopy in white light, you can see clearly there is cancer. So the conclusion that we get for one S according to Paris, JNet 3, NICE 3, SANA 3A 3B, CUDA 4 VN, 2. So this is what we see on optical magnification. So I would like to quickly talk on this one. This is a small formation. This is a planned visit. After confirming that this can be removed in order to conduct a protocol. So we get different modes. So this formation will be rejected en bloc. So the patient does well after this procedure. So going back to what I started from. So the company lives up to those requirements that are there today. We know that everything has to be explained and it has to be in the has to have a legal background, and any technology provider strives to make sure that those classification that we use have to be singular. They have to be used as a single language among doctors. In the remaining 45 seconds, I would like to say that in this video system, what we like is the new edition. You see 2 monitors, and you can this is like an AI, and the second AI that shows you those dots that are needed to to document the visual picture. So any doctor has to know when we write the protocol, so you can see it on the second monitor. So in comparison to the top models, any producer strives to perfection, and there's no limit to perfection. And we always say that we are responsible for what we do. Everything that is shown on the slide, they all live up to the standards, to the world standards. So prospects of visualization, this is artificial intelligence, the Endomate, also Kado that Fujifilm has. So Endomate, this artificial intelligence, it is comparable to the AI that is used in the top equipment providers. And now, if you compare AI of Aohua, if you compare it with other top providers, then you can see, you can compare it, its parameters. Now, going back to what I started with, as a person that conducted this study for self-assessment and self-control, this is the demonstration of the needed dots in examining stomach or rectum. This allows endoscopists to see what has been examined, what has not been examined, and to understand how much quality was provided during a study. No less than 22 dots have to be examined, as was said in previous presentation. So the 300 model, AQ 300 model, provides you with all this information. This is very helpful to young specialists. This is what the protocol looks like. It is all documented. It's all documented on the hard drive, and it can be transmitted from one place to another. You can use cloud technology in order to store the data. Now, regarding the column, use of monitors, so it guarantees objective quality examination. On the left corner, you can see the parts that were examined, the time when there's the time of intubation of the colon, and the time of completion of the procedure and what part of the study examination was provided. On the slide, you can see this is what you will see on the second monitor in the AQ300 model. So you will have this easy to use data to show your point, working in different countries, in different settings, on different using different languages. We are communicating in one language by providing these images on the one and second monitor. So in conclusion, all the companies that are trying to make perfect the equipment, working on Olympus, Fujifilm, in order to say that any endoscopic study examination has to be quality, has to provide objective criteria in terms of quality. It helps to evaluate and provide self-control. Thank you very much for your attention. Thank you very much, Irina Yurievna. Do you have any questions? I have a comment. I had a chance to work on this equipment for 1 month. We say ahua and you say awohua. Now for the quality, I think it is better than the other equipment pieces. There is a video recorder, 1 terabyte. We have a model 200. It's an older one. I believe I can't imagine of what kind of functionality you have with the newer model. I hope that we will have a new model. But I like the 200, the model 200. The way it was produced, there is a hermetic sticker. The sometimes the cup, the lid is leaky and so on. So, but here it is not leaky, so that is very helpful. In routine practice, they are fit for repair. Other producers, you cannot connect those device parts, but with Ahua, you can easily do that. So the design is also, I like the design as well. Thank you very much.
Next speaker is Dr. Batir Bekov Kanat. He is the head of the Department of Expert Endoscopy and Interventional Radiology at the National Research Cancer Center, chairman of the Kazakh Endoscopy Society, coordinator of endoscopy at the Ministry of Health of the Republic of Kazakhstan. The title of his talk is Nuances of Endoscopic Diagnosis in Crohn's disease and ulcerative colitis. So please, Kanat.
Thank you so much for your kind presentation. And my topic is Crohn's disease. Хотел бы сказать, что у нас клиника хоть
to speak that our clinic of oncological profile, but we have the Department of Gastroenterology where selection of therapy is done. Therefore, we have the experience of diagnostic of Crohn, of the azole collector and microscopic collector. And we have morphologists who deal with the diseases of intestine. Therefore, this topic is very close to us. We have deadline. I would not take much time. I understand that people are tired. We had very tense traffic. Epidemiology is not high, but as soon as we started to deal with the inflammatory diseases of intestine, well, the speed has changed. Morphologists not always help us with biopsy, not always can classifications be used, and there can be different transmural deviations, lymphoid tissues, machine, normal content of machine, and availability of sarcosis granular diameter in granulars can be vary, forms localized or spread as to character acute and not structuring and direct. The clinical picture can be various, but mostly over 6 months. When we detected small erosion in near appendix, we took biopsy and it proved to be the disease of the chronic. Well, it can be on smooth asymmetric deviations, discretal, and frequently thickening of the intestine walls. And the main aspects of endoscopic diagnostic for initial diagnosis, secondary colonoscopy, lengthy chronicle passing, and colonoscopy with obligatory intubation. Gastroscopy is not mandatory, but we had a patient why intubation is necessary. We had a patient after computer tomography. We sent him with suspicion for TR. He was a foreigner. His wife was in the just perinatal center. And actually, at the entrance, he had alcohol with perforation. If we do not intubate it, then another alcohol, we took biopsy, and it was the Crohn disease. And it provided infiltrate, and he was sent to us with esophagus endoscopy. He had lesions at the upper parts. The colonoscopy intubation is mandatory to define the activity of inflammation and to localize the length of inflammatory changes. Capsular endoscopy not always is helpful, but there are limitations. Before undertaking capsular endoscopy, we should take catheter endoscopy and capsular endoscopy only for additional studies of thin intestine, not for thick intestine. For capsular endoscopy, there is a scale of the disease. For enteroscopy, that's the concluding part of diagnostics, gastroscopy, colonoscopy, and with suspicion of inflammatory events, then enteroscopy is done. This year we received enteroscope, one balloon from Olympus, and we did transcendental tractoral. The patient whom I checked, examined, but he was not capable to pass through colonoscopy. Now we see no inflammation went back through anal, looked at underbreast intestine, and met the stricture and ALCA. The patient was at therapy of the so-called remission, but inflammation in the thin intestine proved to be the disease of another nature. The tactics of epithelial formations of large intestine without invasion and dissection. Biopsy, selection of tissues, material is done from different volumes of mucosal parts, and also in the direct intestine, biopsy should be presented in such a way that the material should be kept in several containers. We try to stick pictures wherever it's possible because it is useful not only for us, but it will be very useful for morphologists. The only thing is that there is limitation for not more than 7 pictures. And the sonography, also some small usage in the direct intestine for checking the depth and for suspicion of defect of the cell nature. So, and I'd better show you our cases which we diagnosed in our department. This is a patient with Crohn's disease, preemptive defect of the upper parts of the GKT, and he had very deep ulcers at the level of the lips and tongue and the lower part, and finally in bilicicular there was one outcome. Then he passed through biological therapy and came to control. The deep alcas were improved. We still keep him under control and preserve clinical effectiveness of treatment. You know, different types. Patients quite numerous that we get with alkalitis, and I'd like to show you those who were clinically infected. Frequently we have patients when endoscopic picture is very similar. Morphologists sometimes even find it difficult to determine the substrate, whether it is Crohn or colitis. And with classification, we determine the activity, the expressiveness in grades, and most frequently with alkalitis, the cancer of intestine takes place, and we define the average risk of classification and colonoscopy risk. And there are facts of unknown zone, not to all endoscopists, it's well known. This is a patient with alkalitis, pseudopolyps, and it looks similar to Crohn. Morphologically, it was proved. He was 51, complained to pains and general fatigue. He passed through treatment, morphological conclusion, alkalitis with slight dysplasia. The second patient, he is of interest. There are no anatomic structures. It's unclear in which location. There is no flexibility. But at 70 centimeters, I take biopsy. At 50 centimeters, I take biopsy. At 50 and 70, we come to the thin intestine, but 10-year also is not placed. Anatomically changed picture with alkalitis. Biopsy proved the second picture. I thought that this is lysical colitis. In other places, there were no limitations. Thank you. Thank you very much for your interesting presentation. Please tell us, did you encounter supreme heavy alkalitis? Not yet, but extremely hard cases we did not encounter. I think our gastroenterologist also will confirm. How did you carry out diagnostic if you could not see the difference between Crohn disease and this alkalitis? In any case, we took biopsy, 2 fragments from each location. Separately, we divided flagons, altogether 6 flagons, and morphologist always had the headache of defining the diagnosis. But I would not say that we had so many cases of Crohn disease. And pseudo-inflammatory polyps in the stage of scarring. Sometimes doctor mix whether they are really cases or these epithelial formations. In any case, we look for availability of the drawing of the surface and we determine whether it is polyp or just pseudopolyps. Usually it's pseudopolyp. Thank you. Я не смогу. In blind biopsy, it's costly, but as it is validated by European recommendations, how blind biopsy from 6 locations is rational? Or did you have cases when such biopsy would provide real assistance for further treatment. But if it did not provide results, can we limit with 3 biopsies? I agree with your question. Most frequently, stage biopsy with the suspicion to microscopic polypus. If symptomatic is in place and gastroenterologist send such patients for taking biopsy, we do so and hope that it would be microscopic polypus. But several cases we had lymphocytaral polypus, and we took collagenous polypus was one case. But with alkalitis, when we see where inflammation ends, we take scopy from healthy tissue and from defected tissues. Now the price is even higher. Morphologist one bottle costs 15,000. So
Thank you very much for this presentation. I have a question. When you assess endoscopic activity of the Crohn's disease, what scale do you use? And just do you use just one or do you combine several? In my presentation, there were the scales that I showed. One more question. Then one main endoscopic countries, do you or just to use a certain scale? Let's maybe start with the second question. Since I coordinate our endoscopy, back in the time, I took a grant from Olympus through European office. We developed our book and we distributed them free of charge among endoscopists of Kazakhstan so that we speak one language. This was a request from gastroenterologists. So the aim was to make sure that we use same language. So this all has to be done. Of course, there are certain skills in order to save your time. Yeah, I went through them very fast. That they help us assess the severity of the disease, the condition. There are skills that are for colonoscopy that we use on a daily basis. There is a simple scale that doesn't take too much time for the length in Crohn's disease Lewis score. There is for post-operative, if the patient was operated, there is a scale for simple endoscopic for Crohn's disease. Very simple. It's called a simple scale. Very convenient to use in operative practice. Then inflammation status, inflammation grade will be assessed by a morphologist. Here, the length, number, size of the inflammation, presence of inflammation, stenosis. There is the scale. We want all endoscopists to speak one language, to write in a similar fashion. Of course, that's why we use these skills.
Make a simple comment, one comment. Actually, Crohn's disease and ulcerative colitis are chronic inflammatory disease, which means it lasts for a long time. So if we feel a difficulty in differential diagnosis by one-time endoscopy, then you can repeat, you can follow up the patients, and then you can perform endoscopy again, for example, 1 month or 2 months or 3 months later. And as all of us know, acute colitis improves within several months. But if you see the inflammation continues, then we can think of possibility of Crohn's disease and ulcerative colitis. So now I'd like to introduce the very last speaker of today. Yeah, Dr. Gogolev Artem. He's a pathologist at the Center of Pathomorphology, Immunohistochemical, and Translational Oncology of National Research Oncology Center in Kazakhstan. He's going to talk about pathomorphological research in EMR-ESD, key success factors. Yeah, please go ahead. Microphone.
Добрый вечер, глубоко уважаемые.
Good evening, dear friends, dear presidium, dear colleagues. I will try to briefly describe how we can improve our cooperation and interaction between endoscopists and pathologists. As part of multidisciplinary team, we have to work together. So I will be talking about endoscopic resections of the submucosa. This is a very beautiful method that helps to fully treat patients with early cancer, early neoplasms. They help us preserve an organ and help us to stratify a risk. One of the key stages of this study at the pathomorphological is pre-analytical stage. It starts with the resection of this preparation from the organ, and so the main part of this stage is done by the endoscopist. So a quality material that is done by an experienced endoscopy that was taken and sampled and by endoscopy is an important part. So the points that I would like to talk about is referral to histology. So it has to include an entire full information on clinical localization of the process, short history, clinical diagnosis, and data from previous histologic studies. Morphologists cannot do without this information. So this is a critical information for us. Another Marzak, which already mentioned this. I feel comfortable when I see endoscopic pictures. We morphologists, so we need to see this information, to have this information. We have to see the changes, so we have to see deviation from the norm. And it is for us very important what it looks like, how this and its features, also macroscopic features. The next point is the documenting the material on a certain platform. So there are certain rules that have to be observed in order to provide quality study. First, the material should not be too wide, too extended. It has to be fixed using these needles. So if you look at this preparation on the lower left hand side, when you fix it with a formaldehyde, say they lead to the rupture of the mucous membrane and the loss of important information. So it is important to make sure that you balance it out. Don't stretch it too much and don't bring it too much together. And those needles that are used, the thinner they are, the more information you'll be able to preserve. They have to, they have to, they should not be at the edge of the material of the preparation, because since the muscular layer may contract, and it may lead to rupture of the edges. So you have to make sure that there is a certain distance from the edge when you attach it using the needles. So due to that, we may lose some information due to these ruptures. It is important that a morphologist has to dye the edges. There are several histologic blocks. The lateral projection and the deep part, they have to be marked with different colors. But a morphological lab has to have specialized histologic dyes in order to mark the materials correctly. And there is certain requirement in terms of experience, in terms of dividing it into different parts in order to put in different histologic blocks. The material is divided into fragments 2 to 3 millimeters in thickness. They have to be evenly distributed. They should not be longer than that, because they will put in cassettes, and there has to be perpendicular crosscuts in order to provide quality examination. And with some experience, morphologists are able to correctly prepare these preparations. And this is a very intense, labor-intense work. It is very fragile, very thin layers, and for example, fragments, samples taken from small intestine are very fragile and very thin. So the material has to be taken in full. Polyp parts, they sometimes, when you cut the material, they get lost, they detach from each other. So you should not be trying to save cassettes. So you should be using adequate number of cassettes in order to cover as much to put as much material as possible into the cassettes. So interaction with morphologists, pathologists, is through continuous discussion, ongoing discussion. If pathologists invite endoscopists to their work, this will help us big time. So help sort, mark, create photos, and improve the quality of reporting. And I propose to you to assess, to go to your pathology lab, and in order to know how well it is working, whether they live up to the standards, live up to the rules, how they whether they use certain standards, and so on. At the analytical stage, morphologists have to assess a number of risks that are critical for the prognosis and risk stratification for early cancer of the stomach and intestine. the principles. For example, low differentiation grade, histologic, whether there is a lymphovascular invasion, whether there is a deep invasion, whether there is a tumor on the resection edge, and so on. These factors have to be taken into account. So in the report, in the pathologist report, they have to show the size in microns from the edge to the central part. So from the invasive part till the dyed lateral and vertical sides of the edges of the resection in microns. Using a microscope, this is feasible to provide the required sizes. Also, you are required, a pathologist is required to give staging depending on the architecture of the formation, whether lateral or a polyp with a leg. You use a Haggett level. It has to be shown in the report. Presence of lymphovascular invasion, especially for the upper GI tract. But for the endoscopic dissection of the colon, intramural invasion that happens in the submucous vessels, it is also seen, and it is in unfavorable prognostic factor. One of the important factors is dark spots. In the report, it has to state the number in submucosal dissection, how many of them, this budding, tumor budding, it is done on this on the size 0.785 square millimeters. So pathologists have to have the respective microscopes, but not all labs have such microscopes. So you have to count the buds in a field area of this 0.785 square millimeters. So when you use magnification, on the slide you can see tumor budding, what it looks like. There's a small groups up to 4 tumor cells that characterize how epithelial mesenchymal transfer or transition looks like, and whether there is a high risk of metastasis and infiltrative growth. And one of the discussion points on this slide is the consensus materials of 2016. One of the discussion points that is shown here, that not all of them voted for, the assessment is made on the preparation with hemotaxylin. There are some complex cases, whether those are tumor buds or other buds, tangential buds, they might be pseudo budding, when an assessment requires additional assessments, for example, histochemical examination. On this slide, you can see dyeing the tumor using panseokeratin. Statistically, it was shown that you have to assess tumor budding in tumors that have a marked lymphoid inflammation reaction. In those places, where it is less marked, because there is subda budding happening in this area, because there's inflammation infiltrate that separates structures of the tumor glands, and these fragments, divided fragments, they imitate tumor budding. There was a beautiful study in 2023, published in 2023, on thick histologic cross sections using immune fluorescent method. It was shown in 3D that those are not tumor buds, real tumor buds. Those, when these structures are in the thick, massive infiltrate, those were pseudo buds. There is no consensus on that, but morphologists, pathologists have to do that, to do the study in areas with with less inflammation. No. So there has to be good communication with to improve this communication and reporting, especially in large hospitals with large volume of endoscopic this material, endoscopic material. So this material has to be seen. So this communication helps us improve our communication. Thank you very much. Thank you very much for
Yeah. Yes. Question?
Ахмед, за презентацию. Нам, как эндоскопистам,
Thank you very much for your presentation for us endoscopists. It's very important. Finally, we had a good presentation for post-operational material. The question is, does coagulation affect on the material, the final part of histology, gistology? It happens that the flap bleeds a lot and we have to coagulate each. Or if you use the leg and instead of using very valuable information, you use some bad thing. Thank you for your question. Yes. With gistological studies, we see different changes that take place after coagulation. And this material, if it was subject to different impact, and sometimes frequently we cannot differentiate whether these are fibrosic just events or these changes in tissues on the effect of inflammations. So, and thank you very much for your presentation, excellent presentation. I have two questions. You spoke of single blocks, but if we speak of a stomach, if we diagnose autoimmune gastritis, are there any peculiar features in sampling? The second question, how correct it is when we put in formalin and they should be left in lab. Is it correct? Or there are more optimal methods of forwarding? For small bioptats, it's sufficient to have adequate volume of formalin as 10% formalin and timely transportation. But more effective fixation is as undesirable as not strong, as weak fixation. A small volume of material doesn't require orientation, then there are no special recommendations. Correct marking and adequate filling out of description materials and transportation to lab in formalin. These are all keys for success.
I have one question.
Скажите, пожалуйста, вот иногда
Can you tell us, sometimes during gastroscopy, colonoscopy, this permanent use of graspers, when you take several pieces, sometimes it takes time, and sometimes in graspers, I take 2 pieces. Is it correct, or it's better to separate them? Because for some pathomorphologists, it doesn't matter whether they take each piece separately. I may say if there is too strong pressure of bioptat, it is reflected in morphology, and we see it in diagnostics. And you need to carry out mini service study whether there is difference when you take one piece or several pieces simultaneously. Only this is how you can check it.
The importance of submucosal cancer invasion depth and cancer involvement in the lymphovascular involvement of cancer cells. But I heard that some pathologists say that the accurate evaluation of submucosal cancer invasion depth and lymphovascular invasion is difficult under routine hematoxylin eosin staining. So some pathologists say the recommends immunohistochemical staining for muscular mucosa marker, a smooth muscle marker, Desmin staining, and some vascular endothelial cell marker, CD31, CD34 staining, and lymphatic endothelial marker. What's the D240? So, do you think those immunohistochemical staining is necessary in all early cancer cases, or do you think it can be performed selectively for ambiguous, difficult cases?
Thank you for your question. I think not all cases we should use immunohistochemistry for evaluation of lymphovascular invasion or tumor binding. It may be difficult cases, and experienced morphologist can evaluate difficult cases when we have subspecialization for endoscopic material on gematoxylin and resin slides.
Can I say one comment? Я хотел прокомментировать, что Артем Борис
I would like to make a comment. Anton Borisovich strengthened our pathology team. He moved from St. Petersburg. He worked with Mr. Skachenko. we are happy that he didn't like it in Almaty. He came to Astana and works with us. He didn't like it in that city, but now he works with us, and we are very happy to have such a strong specialist. That he reviews the way we like it, and we are very happy with the outcome, with the results of our work, our multidisciplinary teamwork. So thank you very much for participating in this conference. We are happy to see you.
Sorry. Yeah. So you talked about many important things, but what I was impressed most was the former part of your discussion. So you said the discussion among us is very important. I completely agree with you. So the pathological diagnosis might not be the final or the perfect one, in spite of every effort of the pathologist. And yeah, we endoscopes need pathologists to make a correct diagnosis, but for you, pathologists may need some endoscopic information, some clinical information for your diagnosis. So the discussion between us and us endoscopists and the pathologists can be very important. So if there is some discrepancy in what the endoscopy think and the pathological diagnosis, if there is some discrepancy, and also should ask the pathologist and give some clinical information and discuss the matter until you are satisfied with the result of the pathological information, I think. So yeah, it's just like a comment. And
Thank you.
yeah, I'd like to say more. In Japan, if we have such congress, endoscopic conference, we usually have several pathologists there together to discuss the matter. So, and we often talk about a few cases for a long time. One case for 30 minutes, even 1 hour on one case, and we give many opinions clinically, and the pathologists will give opinions, pathological aspect of view, and both of us, pathologists and endoscopists, can learn much more from the conference. So, what do you think of that? Do you have such a system in your country?
We work in very strong communication with our endoscopic specialist. We see the photo material of an endoscopy resection. We discuss our cases and clinical information and some laboratory tests. So it's personalized treatment and
Yeah, yeah, yeah. Oh, yeah. Thank you. So, yeah. So you need endoscopic pictures too for the diagnosis.
yes, and endoscopist and pathomorphologist see the patterns and it's visual information at first. So we need native photo material for our diagnosis too.
Thank you for saying that. Thank you.
Uh, Sorry, oh yeah, I just want to share my experience. Actually, I totally agree to Professor Kashida's opinion that cooperation between endoscopists and histopathologists is very important. Actually, it was about 15 years ago when I was much younger than now, and at that time I performed endoscopy mucosal resection for a some mucosal cancer-like lesion in colon. But the histopathology result was mucosal cancer with clear resection margin. But I thought that it looked like submucosal cancer, even deep submucosal cancer. But it was a very busy it was a very, very busy outpatient clinic when I found the histology report. So I thought that I will consult to the histopathologist after the end of that outpatient clinic. But unfortunately, I forgot asking the histopathologist again, and so the patient was followed up without any intervention, additional intervention, and I don't remember the exact time interval, but it was maybe 4 or 5 years later. The patient presented with multiple hepatic metastasis, and I was shocked. And I saw the initial endoscopy pictures again, and I at that time I consulted the pathologist again. I asked him to see if it is really mucosal cancer or if there is any chance of some mucosal cancer. And the pathology said to me that after re-evaluation, he said to me that it is deep submucosal cancer, and it has also tumor budding. And so, yeah, I was very sad and I was very unhappy at that time. But anyway, we endoscopists should be, yeah, the pathology is very important. But as Professor Kashida said, pathology is not always 100% correct gold standard. So we endoscopists also look at the endoscopy findings very cautiously. And if we have some questions about the histopathologic diagnosis, then we should communicate very, how can I say, very actively with our histopathologists.
Thank you for your comment.
Yeah, thank you again for your nice presentation. Thank you.
И в завершении нашего Hiroshi Kashida, please, final words.
Yes, because you asked me, I'd like to make a brief comment on today's conference. As I said during my presentation, I visited this country 12 years ago. And actually, what I felt at that time that endoscopy was a little bit behind in this country. Equipments were declined, and knowledge and technology, especially therapeutic technology, was a little bit behind. I felt that. But today, 12 years later, I was surprised to see many good presentations on the knowledge and technique of endoscopy, and I was really impressed. So, 12 years made a big difference. And but during the COVID, we didn't have the opportunities to have such conference in real face-to-face conference, and we had only Zoom conferences. But for me, such kind of a face-to-face conference is very important, not only to acquire new knowledge, but also to understand what is important about the new technology or new treatment option. And you can discuss the issue very deeply if you meet the person face to face rather than meeting in Zoom just online. So, yeah, we have one more day for this conference. Tomorrow is the live demonstration session. But anyway, yeah, I think this conference, this Central Asia conference, is very important for you. And so I'd like you to continue this conference as long as possible So this is only the second time, but you should have third, fourth, and fifth time, and you can make it bigger and bigger or more deep in discussion. Yeah. Thank you for your kind invitation. I really enjoyed today's talks. Thank you very much.
Arigato Professor, for your warm words about us, about our conference. Құрметті әріптестер, бәріңізге көп рахмет.
Dear participants, thank you so much for your participation. Today you found time, regardless of your work. And this is the first day, the end of it. And tomorrow we will have operational translations at 9. We will start and we will have dear friends, dear guests. Thank you very much for finding time to arrive to us and participate in this conference and share with us your presentations and experience. I'm sure it was very interesting for our specialists, especially. We will try to increase the number of foreign experts from Japan, and we will try to share two sections so that child endoscopy and tracheal endoscopy would be separately, and we will try to have traditional endoscopy and also exhibitions of equipments. The number of experts with every time will be increasing. We are sure of that. And now is the time to make a group photo of speakers and then of all participants. Tomorrow we will have the day of operations. They would be live. Two dissections of intestines, including Professor Toshiba, one in resection with the help of device of clips and 3 HPG. And there we have transplantation biliary structures. The day tomorrow will be no less exciting. I will be in clinic, but my deputies will take care of all logistics. Thank you very, very much.